then it's still good afternoon or good evening.
Okay.
So I have my 3 presenters here.
ম্যাডাম খালি স্যার আসে নাই, স্যার আসলে শুরু করব।
আচ্ছা, এখনো 6 মিনিট বাকি আছে।
স্যার ওই 3টা সেশন আপনি চেয়ারপারসন। ওকে স্যার।
স্যার ভুলে গেছে না?
আমি স্যার জয়েন করলে তুমি স্টার্ট করবে, একেবারে গুড ইভিনিং বলে তুমি শুরু করবা যে ফার্স্ট ডে সেকেন্ড সেশনে আমরা যাচ্ছি, তুমি নিজের অ্যাপোর্টে পরিচয় দিয়ে তুমি সরাসরি শুরু করবা, ঠিক আছে? স্যার জয়েন করে নি।
ওকে।
We have 2 very interesting hysteroscopic presentations in this session.
I think so.
And Dr. Selva is there, who is dealing with HIFU, another interesting thing.
I think.
Dr. Maruf, do you believe that it will be available registration of this session later on in the future?
You want a recorded version?
No, I just want to know if in the future it will be available the registration of the entire session.
Sir, it will be available. We will record the whole session for 2 days and we will upload it in a Google Drive. And I will provide you the link. You can go there.
Thanks a lot. Thanks a lot. Thank you very much.
Thanks, sir. Welcome. Start join করছেন।
What is the situation of the COVID in your country?
Still not bad.
Okay.
Still we are in the low range, not increasing still. But I think in some countries it's going faster and faster.
Okay.
Still not affected by Omicron.
But I believe that Omicron it is not very dangerous as the other variants, the original variants. So the more you pass the time, the less is dangerous the variant. So we hope to continue so.
Our President, Professor T.H. sir has joined.
Assalamu alaikum, sir.
Sir, unmute করে নেন।
আসসালামু আলাইকুম স্যার। স্যার আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম। আচ্ছা, সেদিন তুমি ফোন করেছিলে?
জি স্যার, স্যার আমি ফোন করেছিলাম।
আমি ভাবছিলাম জুনিয়র কেউ। ঠিক আছে,
It's okay, sir, no problem, sir.
সবাই তো চলে আসছে, আমরা কি শুরু করে দিব?
হ্যাঁ,
শুরু করে দিব ভাইয়া।
1 মিনিট
শুরু করে-
বাকি আছে।
স্যার কি বলেন দেখি? স্যার
টাইম তো
1 মিনিট বাকি আছে স্যার।
ঠিক টাইম মতো করো, 1 মিনিট 2 মিনিট বাকি আছে।
ওকে স্যার।
3টা বাজলে তুমি শুরু করে দিবা।
ওকে।
We will start exactly at 3 p.m. local time.
2 minutes remaining.
we'll start exactly at 3. Just less than 1 minute to go.
Yes, sir.
It's 15 hours.
Just 3টা বাজে কিন্তু এখন। I think you can start.
Yeah.
আমাকে শুনতে পাচ্ছ না?
Okay, let us start.
আমি শুরু করো।
Respected chairperson, honorable speakers, my dear colleagues and respected audience, Assalamu alaikum and a very good evening. This is Dr. Rebecca Taranum Shammi, Consultant OBGYN Department of Sir Solimullah Medical College and Midford Hospital, welcoming you all to the 6th International Virtual Scientific Conference of FSSB. This is the 4th session. The session will be on endoscopy in infertility. Thank you very much, our organizer, Professor Maruf Siddiqui, for giving me the chance to be a part of this virtual conference. This conference will be sponsored by Healthcare Pharmaceuticals, and it will be chaired by our 2 respected and honorable chairperson, Professor Dr. A.H.M. T. Choudhury, sir. He is the chairperson, first chairperson, and he is the professor, Department of Obs and Gynae, Bardem, former president, OGSB, Suffolk, BCPS. He is the former vice president, AOFOC, and he is the president of our Fertility and Sterility Society of Bangladesh. He is the recipient of Independence Shadhinota Paduk, the highest national award from Bangladesh government. The King of Nepal decorated him with Gharka Dakshin Bahu medal. Our second chairperson is Professor Dr. Laila Arjuman Bani, ma'am. She is the treasurer of FSSB, President PCOS Club of Bangladesh, and she is the past president OGSB. She is the chief consultant and head of Department of Obs and Gynae, Labit Specialist Hospital, Dhaka, Bangladesh. Our session sponsored by Healthcare Pharmaceuticals, and this session will be conducted by our moderator, Professor Dr. Shahi Farjana Tasnim, ma'am. She is the Vice President OGSB outside Dhaka. Now, I request our moderator to conduct the session. Thank you.
Thank you, Dr. Taranum, for giving me the opportunity. Assalamu alaikum and a very good day to you all. It's my true pleasure to be a part of this prestigious session as a moderator. So first of all, I would like to extend my heartfelt thanks and gratitude to FSSB for giving me the opportunity. However, this session is session 4. In fact, it's a session of advanced technology for the management of uterine fibroid, both intracavitary and intramural. We all know that traditional hysterectomy and hysterotomy for myoma has been largely replaced by hysteroscopy, which has been by hysteroscopic myomectomy, which is the procedure of choice in some selective cases for having so many advantages, especially in the field of improving fertility. So I think this session will be very much beneficial for all of us. We'll be able to learn a lot from this session regarding hysteroscopic myomectomy and other advanced technology. We have 3 world-renowned speakers among us. There is a gentle reminder that time allocated for each speaker is 20 minutes. So my humble request to every speaker to finish their talk on time. Dear viewers, if you have any questions, please put it in the chat box. That will be answered after the session, if time permits. Now, it's my immense pleasure to call upon our first speaker, Professor Luigi Montevenci. Now I'm going to read his CV, Dr. Luigi Montevenci. He's from Italy. He's working as his own professor for professional studio in Rome, owned by him, which is named by Ars Medica of Rome. He is the first level manager in the Department of Obstetrics and Gynecology of the Regional Hospital, Steinfeld, Cassia, in Rome. He is working at School of Genital Pathology of National Cancer Institute of Milano. He has a great specialist experience in the different aspects. And he is also, the most important thing is that in 1981, he bought the first Hamos micro colpohysteroscope sold in the world. And since then, he performs office hysteroscopic and microcolposcopic diagnosis. Professor Luigi Montefesi, sir, over to you.
Thank you very much for your kind presentation and for this invitation to participate in the 6th International Virtual Scientific Conference. First of all, I want to share with you that I have no conflict of interest in any problem in this presentation. Just to remember that in my topic, I will speak about the hysteroscopic myomectomy. What is the frequency of myomas? Uterine fibroids are common. 1 in 5 women may have fibroids during their fertile years. And which diagnostic technique we can have to diagnose a fibroid in the uterus? First of all, the ultrasounds, and best the 3D ultrasounds can easily appreciate the involvement of the uterine cavity or the other parts of the uterus in fibroids pathology. Echohysterography can allow us to better evaluate the importance of the fibroid in the uterine cavity involved in infertility or bleeding. Color Doppler can also help us to evaluate the vascularization of the fibroid all around and differentiate it from another more dangerous mass. And last of all, the magnetic resonance can allow us to study the relationship with the other organs inside the abdomen. Hysteroscopy, however, is the best tool to investigate not only the presence of a fibroid inside the uterine cavity, but also its vascularization, looking at the aspect of the endometrium of the patient, and also the pedicle and the vascularization. In this image, we can clearly look at the pedicle of this fibroid inside the uterine cavity. Which location can have the fibroids? Myometrial in the muscular wall of the uterus, submucosal immediately below the surface of the endometrium, subserous immediately below the outer surface, the serosa of the uterus, and pedunculated. They occur on a long stem or pedicle outside the uterus or within the cavity of the uterus. Do we need to treat fibroids? It depends from several factors: age of the patient, general health, severity of symptoms, location of the fibroids. We must know if the patient is pregnant and if she wishes to have children in the future. Just to remember that at least 34,000 myomectomies are performed annually in the United States as an alternative to hysterectomy for women who want to preserve their uterus, regardless of their desire for fertility. We have many minimal invasive treatment for fibroids: uterine artery embolization, cryoablation, using the magnetic resonance guided to destroy uterine fibroids. But I have to speak just about endoscopic myomectomy, and in particular, remember that laparoscopic and hysteroscopic approach is the best one for the patient as a result from a critical review of the surgical treatment of all fibroids. I just have to speak about hysteroscopic myomectomy this morning. So I want to remember that we have three types of fibroid, G0, G1, and G2, depending on their involvement in the muscular layer. This is the European hysteroscopic classification. As you can see in the short video, fibroid type 0 is completely inside the uterine cavity, and if we treat it by a hysteroscopic point of view, we leave a very huge space of muscular layer. Type 1 is 50% in the myometrium, and type 2, G2, is more than 50% in the myometrium. So the criteria for choosing the treatment is different, because we can use hysteroscopic resection in patients with myoma G0 or G1, and in patients with myoma G2, we can perform a hysteroscopic resection if there is a thick muscle layer under the fibroid to prevent inadvertent perforation of the muscle, or laparoscopic myomectomy is if the muscle layer under the fibroid is less than 4 millimeters. Otherwise, we can try, as I will show you in a next video, we can try to convert the G0 in G1 or the G2 in G0 to perform a hysteroscopic resection. Other cases, it depends from the other factors that we have examined before, and from the desire of the patient, from the expertise of the surgeon. Here is just to show the traditional hysteroscopic resection. We can insert the hysteroscope inside the uterine cavity, push the loop behind the fibroid, then retract using current to cut and to coagulate the vessels of the fibroid. So we can progressively have some slices of the fibroid, reducing it in the diameter, and so that we can pull out of the uterine cavity small pieces of the fibroid until we can reach a complete enucleation of this mass. Just to remember that we have always to observe the boundary between the muscle and the fibroid in order to respect the pseudocapsule. I will speak after which is the pseudocapsule. In this video, we can look at the first cut that we have to apply on the fibroid. Then we can continue to using the loop to cut and coagulate the small vessels of the fibroid, always cutting inside the fibroid mass, respecting the normal endometrium and looking, as we can see here, if there is some other fibroids behind the muscle. Here we can easily differentiate between the normal mucosa and the fibroid. Sorry. Let's go on. I just want to show you some special cases. In this case, we can watch the video. It was a patient who was submitted to a previous dilatation and curettage for abortion, and there was a very thick adhesion between the fibroid and the uterine wall. In this case, we have to first introduce the hysteroscope and pressure with the tip of the endoscope in order to break the bridges of adhesions between the fibroid and the wall of the uterus. Pushing with the microcorpohysteroscope, we can clearly see the fibroid fibers and the adhesions fibers that breaks under the pressure of our hysteroscope until we can completely have a separation between the anterior wall and the superficial layer of the myoma. Here is very clearly visible the tension that we can apply against the adhesion in order to break this adhesion. Then we can retract some millimeters the hysteroscope and look at the general cavity in order to evaluate if we have completed or not the adhesiolysis. As you can look, the more we break the adhesion, the more the posterior myoma appears inside the uterine cavity. And we have to continue to apply the pressure against the adhesion in order to completely separate the anterior surface of the fibroid from the anterior wall of the uterus. Here it's clearly visible just a small area residual of the adhesion, and the submucous fibroid is best visible onto the posterior wall of the uterus. Then we can complete the adhesion, and once we have completely break the adhesion, we can start to the resection of the fibroid using the loop as I showed before. So let's go on. This is a type G0 performed with traditional resectoscope. I just want to spare some time. I go ahead just to show how it's possible to perform a resection of the fibroid inside the uterine cavity until we can reach the area where the fibroid was connected to the muscular layer on the posterior wall. Here is the residual hole after cutting completely the fibroid. We have also to remove every area and to look if there is any bleeding from the bed of the fibroid. Here is the completely removed the area and the uterine cavity. But I wanted to show you also other technique to remove fibroid. This is a video from Professor Giuseppe Bigatti, who invented the shaver to remove the fibroid. As you can look in this wonderful video of Professor Bigatti, how this rotating blade can, without the use of current, completely remove a fibroid from the uterine cavity. There is a rotating blade, and the aspiration of the fragments of the fibroids can completely remove the fibroid from the uterine cavity. So it is another opportunity to remove completely and to treat by hysteroscopic point of view every submucous fibroid with best results, as you can look in this video from Professor Bigatti. So this is another case of myoma G2, who is very deeply involved inside the muscular layer. And sorry for the no. Sorry. Here is another kind of fibroid G2, and we use the treatment with scissors to change the G2 to G0. Why? Because this fibroid is too close, as we can look in this video. Sorry, it was too close to the tubal ostium, so it can be very dangerous, the risk of perforation using the normal cutting of the fibroid. So we prefer using the scissors to enucleate completely, cutting the inside the pseudocapsule, and using the scissors also to push the fibroid inside the uterine cavity and to change the G0 fibroid, mainly involved inside the uterine muscle, very close to the tubal ostium, to transform, as I told before, the G0, the G2 fibroid into a G0 completely inside the uterine cavity. So after we remove the fibroid from its bed, we can complete the normal resection of the fibroid with the normal resectoscope without the risk of perforating the muscular wall in the area where the muscular wall is very thin, so minimizing the risk of perforation in this case. Here you can clearly see the fibroid totally enucleated inside the uterine cavity, and so we can complete this myomectomy using the normal resectoscope. I just want to remember you the neurovascular autonomy of the fibroid pseudocapsule. This is very important because, as Professor Tinelli said in several publications in many important reviews, that maintaining the integrity of the myometrium during the myomectomy has two advantages. First, the repair process is better and is also beneficial for the reproductive outcome of the patient. And secondly, there are less bleeding using the myomectomy inside the fibers of the pseudocapsule. So in conclusion, I hope I have respected my 18 minutes scene. Hysteroscopic myomectomy is a safe and effective technique, and it should become the first option for patients with that desire to preserve the uterus. The respect for the pseudocapsule ensures a minimal blood loss, because if you cut inside the pseudocapsule, you have a minimal blood loss and also a best repair. And third, the risk of hysteroscopic myomectomy increases when the indications are not correct. So if you want to cut a G0 fibroid with a very thin layer under the fibroid, you have a very high risk of perforation if you want to perform a hysteroscopic resection. And in this case, it is preferable to perform a laparoscopic resection. Even if you open the uterine cavity, you have many risks and you can better dominate the surgical procedure. So thank you very much for your kind attention and for invitation in this important international virtual Congress. Thanks a lot to everyone.
Thank you very much, sir. Thank you for your wonderful presentation on different aspects of hysteroscopic myomectomy. We came to learn the different tips and tricks on hysteroscopic myomectomy regarding when to go for hysterectomy, myomectomy, when will go for laparoscopic myomectomy, depending upon whether it is in the G0, G1, or G2. And we should always respect the pseudo capsule of the fibroid. It is an important thing to remember. Thank you, sir. Thank you for your wonderful presentation. Now it's the time to call upon our second speaker. It's my immense pleasure to call upon Professor Gianpietro Gubini for his presentation. He will be talking on mini resectoscope in hysteroscopic surgery. Now I'm going to read the CV of Professor Gianpietro Gubini. He has got his MD degree from the University in Medical Science at the University of Bologna in 1972. 2003, he was the head of the gynecologic department in Maggiore Fortunata Toniolo Clinic, Bologna, Italy. He is the creator and developer of the Gubini mini resectoscope. We all of us know, and many of us Bangladeshi hysteroscopic surgeon use his Gubini mini resectoscope, sir. In 2013, he was a member and head of the Scientific Commission of the Italian Society for Gynecological Endoscopy and the editorial board for practical guideline in office hysteroscopy. He is the associate professor and tutor of hysteroscopic surgery in numerous medical institutions. He is the founder of MESTOP, Centers for Minimally Invasive Treatment of Menorrhagia. Sir is also the member of American Association of Gynecologic Laparoscopists. Right now, I would like to call upon our honorable guest speaker, Professor Gianpietro Gubini. Sir, over to you.
Excuse me. Good morning. And excuse me, this excuse me a moment, please. A moment. Okay. Okay. It's okay.
Perfect, speriamo bene.
Perfect. Okay, good morning, and thank you for the kind invitation. I speak about the mini resettoscope in hysteroscopic surgery in infertility, and I am Gianpietro Gubini. I am the inventor of the Gubini mini resettoscope, and I live in Bologna. Bologna is a ancient city. Bologna is very old university, and the towers, the buildings, but also for good food, mortadella, spaghetti, tagliatelle, also is very important for racing car, for Maserati, for the Ducati team and Ferrari. But for me, I remember in Bologna, my first hysteroscopic procedure was in the 1980 with my friend Jacques Camus, Bruno Van Arendel, Luigi Montevecchi. And from diagnosis, we come to see and treat with Stefano Betocchi from Bari. But the office hysteroscopy by Betocchi system is okay, but the limits at the size, the 15 minutes in operative time, is difficult to remove the fragments. The fragments is the procedure no good, and in 2009, thanks to technological progress, the mini resector was born. This represents an important moment in the development of hysteroscopic surgery in office setting. This is my mini resector, exclusive concept all in one. Cioè, the possibility to do all diagnosis and operative procedure with the same instrument. And welcome in a new dimension in hysteroscope. Why? Because 15 frames, 16 frames is possible by monopolar or bipolar electrode. And in this situation, no dilatation of cervical canal, no alteration of endocervix, easy of the surgical gesture, and small size, no vaginal instrument needed. Anesthesia usually not required. The operative time is shorter. And also, I use in office setting. And no speculum, no tenaculum, no dilatator, but no false passage, no complication in resettoscopic surgery. And they are a variety of loop. This loop is possible monopolar or bipolar. And pathologies with the loop for polypectomy, for myomectomy, in this case for the metroplastic. And indication in sterility. Why is hysteroscopy relevance to intrauterine pathology in reproductive outcome, adenomyosis, endometrial polyps, hyperplasia cancer, endometritis, intrauterine synechia, ismocele, leiomyoma, anomaly Müllerian. And the first problem were in the cervical canal. In the cervical canal, the first problem is the polyps. And by mini resectoscope, the rapid surgical gesture is this very simple and fast to remove. I remove by the loop, and the operative times is very short. And when I have, in this case, polyps, but also the synechia, by loop, I remove the synechia in outpatients. No pain and no electrical, but mechanical lesions. And in this case, I have a normal uterus cavity. But it is possible to do a target biopsy. A target biopsy after the, is possible, the myomectomy. But also, other pathology, ismocele. Ismocele, cesarean ismocele has been associated with postmenstrual abnormal uterine bleeding. But the prevalence is from 24% to 18% of women. But it's possible asymptomatic, it's possible in this case to conceive spontaneously, it's possible also the vaginal delivery. It's correct. But when they are the symptom, they are postmenstrual spotting, they are hematometria, pelvic pain, dyspareunia, infertility, and also the ectopic pregnancy and placenta accreta. And the fertility. The fertility is altered by cervical inflammatory tissue, by mucus quality, the sperm transport, infertility, and also the menstrual blood, endometritis, and embryo implantation is important for infertility. And the environment and presence of inflammatory tissue could affect embryo implantation. The situation is similar to a tubal phlogosis, hydrosalpinx. The same situation is necessary to remove. And CSD might impair fertility because the persistence and accumulation of menstrual blood in the cervix negatively influence creating a toxic environment. This cervical canal and by stereoscope, this is the fovea of ismocele. It is correct, the correct vision by stereoscopic procedure. And this is my ismocele repair by mini resectoscope. The first step, second step, and next, the new step, and to objective to restore the continuity of the cervical canal. I remove fibrotic and inflammatory tissue. And when residual myometrial thickness before and after hysteroscopic procedure is increased. The before and after hysteroscopic procedure, and the volume of ismocele before and after is reduced. It's perfect for new canalization of cervical canal. And pregnancy rate, hysteroscopic, laparoscopic, vaginal procedure, pregnancy rate is very good by hysteroscopic procedure. And also, the complication by hysteroscopic correct procedure is 0.3%. It's okay, but In uterine cavity, the hysteroscopic procedure is important first for chronic endometritis. And chronic endometritis in your country is very important. Mycobacterial tuberculosis by Kulmar, my friends, is very manifest as infertility, menstrual irregularities, and abdominal pain. And also Asherman syndrome by hysteroscopic procedure is correct diagnosis and treatment, and also adenomyosis, superficial adenomyosis, as possible identified by hysteroscopic and also by ultrasound procedure. But polyps. The polyps, I remove polyps for procreative, and the indication is correct. Why? Because the endometrial polyps interference in sperm transportation, is interference in inflammatory change. And by hysteroscope, I remove, in this case, in outpatients, in this case, by ellipse and by bipolar current. The loops is very little. Correctly, I remove these polyps and completely remove in this situation. Or when I have a large planted polyps, I use in this case monopolar pulsed current. The fragments is regular remise after the passage, the remove is completely. And also today, I remember the endometrial cancer by hysteroscopic approach. It is used in young women desiring pregnancy. In this case, conservative treatment is based in operative hysteroscopic procedure and hormone therapy. And myoma. Myoma, Montevecchi speak about the size, the localization, the number, and by mini resector, the intracavitary component of the myoma was removed. I using the conventional slicing technique, and the fragment I remove correctly by loop. No problem for remotion. And after it's possible to treatment of intramural myoma. After the electric cutting loop was replaced with a non-electrified metallic loop. The cold loop mechanically disconnected the fibroconnectival bridge anchoring the myoma to pseudocapsula. In this case, I remove completely the myoma. The myoma is free in the cavity. The fovea is correct for new pregnancy. And when I have Mullerian anomaly, in this case, the Mullerian anomaly is associated with increased problem, and is correct. In my classification, integration of hysteroscopic and 3D ultrasound produce a geometrical model. The different model for the correct chirurgy by mini resectoscope with vaginoscopic approach without dilatation, the cervical canal. I use the Collins loop for correct section of septum. The gestuality is correct, no invasive. I have the good results. And when I have the new problem, the T-shaped uterus. T-shaped uterus, different techniques and instruments have been used for hysteroscopic metroplastic. including scissor, resectoscopic surgery, and to promote a consecutive increase in T volume in the uterine cavity. In my experience, this is my uterus shaped by mini resectoscope. The cervical is correct. This is cavity. The wall I section by Collins loop. Is a quick, a simple surgery. I section outer wall correctly 1 centimeter. Electrical loop only. Gestuality is correct from the isthmus. And when I have new pathology, unicoronated uterus, in this case, no dilatation of cervical canal, I remove by Collins loop the first time the wall. I section 1 centimeter of wall. After this, I remove fundus. And after, in lateral wall, the incision is 4 centimeter next to isthmus. The final result is this. Is this before and after my chirurgy? The finish, the final. Take message. In order to improve reproductive capacity, not only the first 5-6 days of embryonic development are important. It's okay, but also the anatomical factor, say, influence the follow-up 9 months. Intrauterine pathology clearly affects reproductive outcomes, and technological advances allow better diagnosis and adequate treatment thanks to outpatient hysteroscopy. Minimal invasive surgery and infertility is today possible by miniaturized instrument, painless, less risk, treat immediately, no stay in hospital, no anesthesia. Advantage, I use the monopolar or bipolar electrode. Today is this time to propose again that experience for the benefits of our patients. And this innovation, this benefits for all women. Thank you very much for your attention.
Thank you very much, sir. Thank you for your wonderful presentation on use of different uses of mini resectoscope 16FR and some clear videos in different diseases rather than endometrial polyp and myoma like Mullerian anomalies, Asherman syndrome, isthmosil, genital tuberculosis, so and so on. We learn a lot from your lectures, sir. Thank you very much to enrich our knowledge. Thanks once again.
Thank you.
Welcome, sir. Now is the time to call upon our third speaker. Now I am going to call upon Dr. Shavalaraja Subramaniam for his speech. He will be talking on HIFU, for the management of myoma and adenomyosis. Now I am going to read the CV of Professor Savalaraja Subramaniam. Is the Master of Reproductive Medicine from Sydney, Subspecialist in Reproductive Medicine, Bachelor of Laparoscopic Surgery from Belgium, Consultant Obstetrician and Gynecologist. He is IVF Specialist and Laparoscopic Surgeon. He is the past President of Obstetrical and Gynecological Society of Malaysia. He is the Chairman of Obstetrical and Gynecological Society of Malaysia. He is the past board member of International Society of Gynecological Endoscopy and is the editorial board journal Gynecologist and Gynecological and Minimal Invasive Surgery. Sir, it is the time for your talk. I am my warm wishes and warm welcome for Professor Savalaraja Subramaniam. Sir, over to you.
Thank you for the kind introduction. Can I share my slides? Okay. Firstly, let me thank the society for inviting me and also for Dr. Maruf for introducing me to the society. So I'm going to talk about this topic. It is called HIFU for myomas and adenomyosis. Can you see my screen?
Yes.
Okay.
Yes,
right.
Sir.
Yes. Okay. So what I'm going to do is, let me see 1 second. This is my disclosure. I run an ultrasound-based HIFU center in Makuta Medical Center, Malacca, Malaysia. Now, this is what I'm going to discuss today. First, I'm going to explain to you all what is HIFU, why I got interested in HIFU, what is the difference between MRI HIFU and ultrasound-based HIFU, advantages of ultrasound-based HIFU over MRI-based HIFU, benefits of HIFU, my journey of starting HIFU services in the private sector in Malaysia. I think I decided to put this in so that you can understand the problems that you may encounter when you bring such a service to your country. How is the training for HIFU? And then I'll end with some cases of HIFU that I've performed over the last 5 months. What is the future? And also conclude. So the first question is, what is HIFU? Now, HIFU basically means it stands for high intensity focused ultrasound. We use focused ultrasound beam to ablate fibroids and adenomyosis. Now, in order to understand, I'll just show this video. Okay, so an ultrasound beam is brought to a tight focus. And what happens is that this ultrasound beam is then brought into the uterus, and then we can ablate the fibroid using this ultrasound beam. And the idea is it only ablates that focal point and not any other areas. And this is the machine that I use. It's called the JC200. And so what happens is that this transducer will produce the beam, and the patient will be lying prone on the machine, and the transducer will then focus the beam into the fibroid. So this is how ultrasound-based HIFU is performed. So now the question is why I got interested in HIFU. Now, I first heard of HIFU many years ago. I'm sure many of you all have heard about it. And my university that I graduated from is the University of Malaya in Malaysia, bought the MRI-based HIFU some 15 years ago. But the reviews and feedbacks I got from doctors and patients were not very good. And so I rarely referred my patients for HIFU treatment. I thought HIFU treatment is a waste of time, as we all can do laparoscopic myomectomy. So in 2017, I was again introduced to this new HIFU modality called ultrasound-based HIFU when I was at a meeting, an APH meeting in Bali in Indonesia. And my friend, Dr. Lee Kin Wai, also started the Singapore HIFU Center in 2018. And he told me all the benefits of this new technology or new way of treating fibroids using an ultrasound-based HIFU. So basically, there are actually two different types of HIFU machines, if you all don't know. The first is what we call as an MRI-based HIFU. This is made by Philips and GE. And the ultrasound-based HIFU is actually made in China. It's made by a company called HIFU in China and in Chongqing, China. And this is how the machine looks like. They have got three different types of machine, and this is the machine that I have got. Now, what is the difference between MRI-based HIFU and ultrasound-based HIFU? Now, this is an MRI-based HIFU transducer. This is an ultrasound-based HIFU transducer. The MRI-based HIFU transducer movement is limited by the size of the hole in the gantry of the MRI. Because this is in the hole of the MRI. You know how MRI is? It's a hollow structure, and this sits inside. So it is movement is actually limited. As opposed to this, the movement is much more. We can actually move 6 centimeters in any directions in this MRI-based HIFU. So ultrasound-based HIFU, the transducer movement is not limited. The other difference is that the MRI-based HIFU use something called phased array transducer. You can see here there are small transducers here. And the advantage of these transducers is that the focus can be moved without movement of the transducers. Here the transducer have to move to reach the focus, whereas this, you don't have to. You can move the focal point without moving the transducer. But the disadvantage is that the focus of the phased array transducer is by 256 small focal point. So the intensity of concentration is not very good. So the power of the machine is limited. So because they are using small transducers, and the power that we get from this machine is far lesser than the power that we get from this machine, the ultrasound-based HIFU. The ultrasound-based HIFU is a single element, and this is the element. So the focus is very small and intense, and so it is more powerful. So because of that, the MRI-based HIFU uses a lower power and has to do a longer sonication time. So each sonication takes 10 to 20 seconds. So what you do is you place the focus, and then you wait for 10 to 20 seconds to send the beam. And this is not very good for organ like the uterus, because the uterus moves when the patient breathes, when the patient coughs, it moves, and that will not be good if you want to do it for 20 seconds. So it may be good for a static organ like the brain, but not very good for uterus. As opposed to ultrasound-based HIFU, we actually ablate using every second. We can go 1 second by 1 second. So when the patient moves, we can stop the treatment immediately. And that is a big advantage of ultrasound-based HIFU compared to MRI-based HIFU. So the advantages of ultrasound-based HIFU is it is real-time ultrasound imaging when performing a HIFU. That means we are actually looking at the uterus using ultrasound. We're looking at it while we are performing the surgery, the HIFU, as opposed to MRI-based HIFU. You can only do the imaging after the ablation has been done. So the power, as I said earlier, a transducer is more powerful, is larger, and if you get a better movement of the transducer during the treatment, and so you get a shorter operating time. But what is most important is that you can get a higher percentage of ablation with an ultrasound-based HIFU. But what we call as a non-perfusion volume in an ultrasound-based HIFU is far more than that of an MRI-based HIFU. So benefits of HIFU to the patient, as you all know, that it is non-invasive. When shrinkage of adenomyosis and fibroids occur, the uterus will be smaller and will be more amenable to pregnancy. There's reduction in symptoms such as menorrhagia and dysmenorrhea, and the patient can start trying to conceive about 4 months after the treatment. Patient can even have a normal delivery after treatment as opposed to, say, laparoscopic myomectomy. So what happened is that because of this, I got interested in this machine, and I actually visited the center Chongqing in China in January 2019. I was invited, and these are some of the photographs I took in the center. They have got a very highly designated center for HIFU there. And so this I went to explore to see whether this could be a modality that I can bring to Malaysia. And I also was impressed with the number of patents that they have. These are all the patents that have been done. And also I looked at all the papers that have been published on HIFU. There are numerous publications on HIFU by the Chongqing machine. And this kind of impressed me. So I thought, okay, I will bring this machine into Malaysia. But in order for the machine to be successful in Malaysia, I need to get the government. The government has already approved this machine. In fact, the government approved bringing in the machine in 2016. But what is more important is that the medical insurance, the insurance companies in this country should approve this machine for usage for fibroids and adenomyosis. And that was not very easy. So I had to actually engage. Firstly, I had to engage with the Ministry of Health, and I got a report from the Ministry of Health to say that this is a good treatment for fibroid and adenomyosis. And then I had to talk to the insurance companies. And here's a lecture that I was giving to the insurance companies, the doctors from the insurance companies, telling them about HIFU, asking them whether they will approve HIFU treatment by insurance. And I also had to engage with the politicians to see whether they can give me an approval. But what happened is that the insurance companies did not give officially an approval. They told me that you bring the machine in and then we will see whether it will be approved. Another problem in Malaysia is that we have code system. Just like the Americans, we have a code system for any treatment. And fortunately, I was able to persuade the Ministry of Health to give me a code for HIFU, which I hoped will be accepted by the insurance companies to cover for HIFU treatment for fibroids and adenomyosis. Then in January last year, January 2020, I went to Chongqing, China. Here is Dr. Wang Zibiao. He's the inventor of this HIFU machine, ultrasound-based HIFU machine. I went there for training for 1 week, and I worked on liver tissues, and I also worked on models. And then I went to another town called Suining in China, where they do something like 20,000 cases a year, or some huge figures that they do. And I was taught by the doctors there, and I did a few cases of HIFU with them in China. And I came back from China on the 18th of January, and actually COVID started just after that. So in December 2019, the hospital and we have already paid the deposit for the machine, and the machine actually arrived in Malaysia in February 2020. And we started renovating our room. We got the plans designed, and the plans were then sent to the Ministry of Health. The Ministry of Health approved it, and we started doing the renovation. But what happened is COVID struck, and we had, on the 18th of March 2020, we went into a lockdown, and the lockdown lasted for nearly 3 months. So all renovations were stopped. We only could resume the renovation in May 2021, and in June, we completed the renovation. Then comes the problem of trying to get the engineers from China to come here to install the machine. We didn't know how to do it because the whole country was in a lockdown, and there was no foreigners that were allowed to come to Malaysia. Fortunately, in September, we found some loophole, and we managed to get the visas for the engineers, and the engineers actually came in December 2020. These were the machines, they were brought in, and these machines were then installed in my center, and we actually got it all done by December 2020. Next comes, this is how the center looks like. This is a small room, not a very big room. And this is the console where you sit down and monitor the progress. And this is the table where the patient lies down. And this is the machine that provides the water supply. Sorry, this the end is the water supply. The water supply is somewhere here. This is the water supply. And this is how the center looks like. Then I had to actually wait for the hospital license. Although the machine is approved in the government, the hospital had got to get a license to perform the procedure. And finally, after 6 months, we got the license. Once we've got the license, the next step is actually to bring the doctor from China who will come and do the procedure with me, because I have almost forgotten everything, because it was 1.5 years since I went for my training, and so the arrangement is for a doctor from China to come to my center and stay with me for 3 months. And she finally arrived. She had to be quarantined for 14 days, and then she managed to join us. And this is Dr. Huang, who came and started doing the procedure. So we started HIFU treatment on the 12th of July 2021. And it was a challenging time. And this is my training for HIFU. Today, just now, I did number 92 case. And after this lecture, I'll be doing my 93rd case. So we have done 46 cases of adenomyosis, 40 cases of fibroid, and 7 cases of adenomyosis and fibroid. And here, Dr. Huang was sitting with me, teaching me how to do HIFU. She was with me until mid-October, that is for 3 months plus. And we did our 50th case on the 9th of October 2021. And at this time, I was then credentialed to be able to do HIFU on my own. So this is a certificate I got when I went to Chongqing, China, but that does minimal training. And this is the certificate to tell that I am qualified to do the procedure by myself. But I'll tell you that it is not as easy as you think. After even now, I'm doing number 93, I still get help from the Chongqing, China for some difficult cases, how to perform HIFU. Now, before I go on to, I've got another 6 minutes. Before I go on to show you all some examples of cases, I would like to show you this small study which shows that the uterus has got a volume, we all know that, and the average volume of the uterus is about 15 to 56 centimeter cube. If it is a 12-week size uterus, the volume is about 240 centimeter cube. Now, this is important because when we measure uterine volume, we must know what is normal. And this is the average volume of a uterus at 50th percentile is about 81 centimeter cube. At 95th percentile is about 238, and at 5th percentile is 27 centimeter cube. So this is probably the average volume of a uterine fibroid. So when I will be showing you about my studies, my cases, you will understand what I'm talking about. So first case I'm going to show you is a 38-year-old lady, para 2. She was noted to have adenomyosis before a second pregnancy. Adenomyosis started getting bigger during the pregnancy, was given GnRH analog and Mirena in 2019. It was increasing in size over the last 6 months from 3 to 5 centimeters. She had pain in the left groin, pulling pain in the leg, and now on the right side. Her periods were prolonged. She was also gaining a lot of weight with Mirena, so she's not very happy with the Mirena. So this is how it looked. This is the typical adenomyosis that we see. This is a large adenomyoma in the posterior wall of the uterus. This is a large adenomyoma posterior wall of the uterus. This is an MRI picture. And this is we did the HIFU on the 15th of July, one of the first few cases that we did. And this is the pre-treatment HIFU uterine volume, which is 287 centimeter cube. And after HIFU, on 2 months later, on the 17th of September, we measured again. We did another MRI and we measured again. And this is the area of ablation, the adenomyotic ablation. And this is the post-HIFU ablation, that's 133. So if you look at it, pre-HIFU was 287 centimeter cube. Post-HIFU was 133.67 centimeter cube. So it's a reduction of 53.4%, which is remarkable for people with adenomyosis. Now, my case 2 is a 38-year-old lady married for 6 years. She had 1 miscarriage at 5 weeks, no ERPOC done. She had a laparoscopic myomectomy and cystectomy in 2014. IVF done in 2019, 4 embryos and 2 embryos were transferred. She didn't get pregnant. Severe dysmenorrhea for the last 4 years, heavy periods, had blood transfusion recently. And this is her adenomyosis, a large adenomyosis, almost 16 weeks size, 10.24 centimeters by 6.35 centimeters by 10.94 centimeters. The volume of the uterus was 372 centimeter cube. So she underwent HIFU. This is pre-HIFU treatment. This is post-HIFU, 2 months after post-HIFU, and the volume is 201 centimeter cube. So percentage reduction of 44.6%. And this ablated area will still shrink. This uterus will still shrink, and hopefully there will be a 70 or 80% reduction in the uterine volume. And this is, we also use ultrasound. We can't be doing MRI for all these patients. We do 3D ultrasound. This is the pre-operative ultrasound volume, post-operative ultrasound volume. Ultrasound measurement showed a 55% reduction in uterine volume. So this is case number 3, 40-year-old lady married for 7 years, not keen on pregnancy, severe dysmenorrhea, heavy periods. And this is the adenomyosis, a large adenomyosis, another large adenomyosis. And again, volume reduction, pre-operative to post-operative of 38.5%. Case number 4, 41-year-old single lady, adenomyosis for 20 years, had lap myomectomy in 2010. Mirena was placed in 2012, removed in 2016. She was given GnRH analog 3 injections, severe dysmenorrhea and heavy menses. Examination and ultrasound showed a 16-week size, bulky, thickened posterior wall resembling adenomyosis. She also had a small endometrioma. And this is how it looked, typical adenomyosis, a huge posterior wall adenomyosis, how to get pregnant with this kind of adenomyosis. Usually we give up on this kind of patients. And this is after HIFU treatment, post-HIFU contrast. And she still haven't come back for her ultrasound measurements. And this is the percentage reduction is 64.3% from, based on ultrasound measurement, from the 5th, 8th to the 30th of 9. It's about almost 2 months of treatment or after HIFU treatment. Now, case 5 is a 43-year-old lady married for 14 years with no children. periods irregular with some dysmenorrhea. She had a cystectomy in 2012. She was told by another doctor that she has adenomyosis and need a hysterectomy. Examination showed a 14-week size uterus. And this is how the uterus looked like. It is actually a large fibroid. I'm showing you one fibroid case. She wants to get pregnant. Her fibroid was 9.18 times 8.34 times 9.51 centimeters. And the volume was 381 centimeter cube. And this one, she just saw me yesterday. No, this is a HIFU performed. We performed the HIFU on the 12th of October, 2021. And this is how it looked after the ablation. The whole fibroid has been ablated. This full fibroid has been ablated. And so the post-operative ablation was 277 centimeter cube. And the volume reduction was 55% for this fibroid. So this patient, this fibroid will still shrink. These are all dead tissue. So this will still be absorbed by the body, and the uterus will become smaller. And hopefully in about 2 or 3 months, she can try to get pregnant. So what is the future? Can we perform HIFU on unmarried single women when the fibroid that are not so big, say you have 4, 5, 6 centimeter fibroid, not so much symptoms? Can we do HIFU for these patients to shrink it instead of just waiting and waiting and waiting? What about, can we perform HIFU for unmarried single women who are in the beginning stages of adenomyosis? And when is the best time to do HIFU for these patients to prevent progression of disease? These are questions that I think in future we'll be able to answer. We have got patients who have adenomyosis who are single, and they suffer in pain, and we don't know when is the right time to actually start some kind of treatment. Of course, we give them medical treatment, but if the medical treatment doesn't work, can we do something to actually shrink these fibroids and adenomyosis before it becomes too late? So in conclusion, HIFU is a good option for fertility specialists dealing with patients with fibroid and adenomyosis. The machine is expensive, so the cost to the patient can be high. However, the benefit to the patient is enormous. Training in HIFU is not so easy, it's tough. One had to do at least about 50 cases before becoming fairly competent to perform HIFU by themselves. And it took me more. I was not comfortable until I did about 80 patients. In fact, my teachers in Chongqing were saying that you are good enough, please do it on your own. And only 2 weeks ago, I started actually doing completely by myself. HIFU company is always there to help me, even virtually, when performing HIFU. So I can actually dial them up, they can watch my screen, and I can talk to them when I perform HIFU now. Thank you. Sorry, I went 1 minute over.
It's okay, sir. Thank you, sir. Thank you very much for sharing your experience on HIFU, which is indeed the newest and most advanced and expensive method of treatment of adenomyosis and myoma. Now, we came to know the different types of HIFU and their advantages. You have also enriched our knowledge by sharing your presentation, evidence-based presentation and scenario-based presentation. Thank you, sir. We are very much benefited by your lecture. Thanks once again. Now, it is the time for question and answer session. I would like to ask one question for each speaker. My first question to Professor our first speaker. My question is to perform hysterectomy, hysteroscopic myomectomy, what instrument is better? It is mini cystoscope or hysteroscopic morcellator like Bugatti-Shaver? My question to Professor Luigi Montevenci, sir. Do you hear me?
Yeah, sure. Do you hear me? Yes, sorry. I have no experience with the Bugatti-Shaver. I just report the experience of Professor Bugatti, who invented the shaver and has a very huge hospital in Shenzhen, China, made for him and to teach and perform hysteroscopic myomectomy with the shaver. I believe that every instrument can be useful, and it depends from the own experience of every surgeon. So if we can reach the same result with different instruments, depending of each experience, each skill of each surgeon, reaching the same result with no complications for the patients, I believe that it's the same. In other words, for example, I can perform a conization for an intrauterine lesion of the uterine cervix with a loop, with a cold knife, with the laser, with the very high frequency current, but the importance is to reach the same goal. The first one is to completely remove the pathology. The second goal is not to harm the patient with every problem. And the third one is to perform the surgery with the minimal blood loss and the minimal time loss. So usually you can perform better with the shaver, for example, for a G0 fibroid, because it's completely inside the uterine cavity. You can use a physiological solution because you don't use current, so it can be better for the patient. Secondly, you can remove very rapidly the entire mass from the cavity and uterus. So in this case, maybe the shaver can be better. Obviously, in a fibroid type G0, very close to the uterine wall, I believe that the shaver, it requires a very high skill, so that just maybe Professor Bigatti would be able to perform with the shaver, and I prefer to perform this kind of G0 fibroid using, as I shown before, the scissors to remove the main intramural part of the fibroid inside the uterine cavity and then complete with other traditional techniques. I hope I have answered to your question.
Thank you, sir. Thank you. Perfect, sir.
Now,
I'd like to move to our second speaker, Professor Gianpietro Gubini. Sir, there was a simple question for you. You have large experience on this field, but my question is very simple. Question is, during hysteroscopic mammectomy, what should be the ideal intrauterine pressure and what should be the pressure in the hysteromat? To Professor Gianpietro Gubini, sir. Sir, are you here?
Qual è la pressione che tu usi quando fai la...
Okay. In my experience, I utilize my mini resectoscope for the 18% for patients. Only in 20% of patients, I utilize the big resector. The pressure is normal. The pressure is the necessary for the correct vision. But I think the complication they are present when you not have the prevision, the balance of the liquids. But the correct, it's the same for electricity. The good electricity, it is correct for to use, and for distension correct of uterus, I use the pressure normally when I use the resectoscopic procedure. Non so se ho detto bene.
Thank you, sir. Would you please answer another?
Excuse me, my English is very little English.
No, sir, it's okay, sir. It is quite understandable and audible. Thank you, sir. Sir, would you please answer another simple question? During hysteroscopic mammectomy, what should be the power setting? What should be the bipolar cutting current? And what should be the power of coagulation current? Is it 60/60 or 100/60?
It is for me.
Regarding coagulation current, yes, sir. Bipolar cutting, power setting, sir.
La potenza del taglio durante la resezione bipolare.
It is correct for to ask me, but for me is no problem. When I arrive in a surgery room, I control the electrobisturi, I control the pump, I control the correct irrigation for the liquids and for the energy. For me, it's different when I have new electrode, a new electricity sergeant, no, new instrument. And in this case, my instrument is intelligent, come si dice? Is correct for correct energy. But for me, it's no very problem. When I have the big energy, is no correct, but I control, I reduce, I module my, and also irrigation. The good irrigation and good electricity is good for my clergy. And control by myomectomy, by metroplastic, by polish. The important is the gesture correct, the indication, the complication prevent. Okay?
Okay, sir.
Thank you.
Thank you, sir. Thank you, sir. Now I would like to move to our third speaker, to Dr. Savalaraja Subramaniam. Sir, I have no so much knowledge regarding HIFU. Sir, as we are far away, like Bangladesh and some other Asian countries, we are far away from this advanced technology. Sir, I just want to know from you that what's the future of HIFU in Asian countries? What's your hope? To Professor Savalaraja Subramaniam, sir.
I mean, the bottleneck for the machine is the cost of the machine. I think if it becomes popular, just like everything in life, the price will come down. If the price comes down, the price to the patient will come down, and it will be available. It can be available to. I mean, it will be beneficial to many people in many parts of the world. At the moment, the best machine is made in this ultrasound-based machine is made by Chongqing, China, and they are charging premium. So I think it is maybe limited to certain group of people or certain companies. So, for example, if Bangladesh wants to get it, so you can probably get it in an institution, and then everybody goes there and train and use it in that institution. Of course, there will be a cost. The big advantage of the machine is that it doesn't require so much maintenance cost and running cost. Running cost is low. It's only thing the capital expenditure is very high. So the benefits are there, and I can see it after starting usage. I think one of the big benefits is that gynecologists can do it. If you can do ultrasound, you can do HIFU. I think that's one big advantage, as opposed to MRI-based HIFU only can be done by the interventional radiologist or radiologist. So there's an advantage, and also it's quicker. You can do the procedure more quickly than other methods. So, and just like most other places in the world, it was not available in Malaysia, and I recently got it. I'm sure in time to come, you'll be able to get it in your in at least one machine in your center.
So how much cost it about?
It is very expensive. I'll tell you personally, it's not something I don't disclose.
Sorry, sir.
You have to ask. It is very, very expensive.
Okay, sir. Thank you, sir. Thank you very much, sir, for wonderful and interactive question answer session. Now it's the time to take chairperson's remark. For this, at first, I would like to request our honorable chairperson of today's session, Professor Laila Ajuman Banu. She is the treasurer of FSSB and past president of OGSB. Madam, please give your remarks on this overall presentation to Professor Laila Ajuman Banu, madam.
Thank you very much, Dr. Shahi. I think am I audible?
Yes, ma'am.
Thank you very much. Actually, I was just listening this excellent session, having the newer things and newer technology. We are just listening. The first of all, the Luigi Mantici, he has the very much nicely described how the submucous or the grade 1, 2 tumors or fibroids can be removed by hysteroscopy. We are still doing hysteroscopy too, but her methods are very fine, and the classification he has given, I am just surprised actually, the grade 0 and grade 1 and grade 2. So I think he has already stated that it is the 20% in the frequency of fibroid, and already he has described the diagnosis. And at the very end, this is the $1,000,000 question: do we need to treat fibroids in all cases? Actually, this is the problem. Sometimes the patients come with 1 to 2 centimeter fibroid and becomes very much anxious that it should be removed, but sometimes it does not need it. So there is a place of counseling to the patient, and I think a very good counseling is needed here. And the hysteroscopic myomectomy we are also doing, and in our country, some centers outside the Dhaka, they are also doing hysteroscopic polypectomy, myomectomy, submucous myomectomy like this. But and it is actually very advantageous or very much familiar to the patient, because it is sometimes we can do it at outpatient outpatient procedure, or we can discharge the patient just we do the at morning, and we can discharge the patient at evening. And also the advantage that there is minimum pain to the patient. So it is very safe and effective. It should be the and as he said, that it should be the first option. And I also should say that it should be the first option. Now our second speaker, Professor Pietro Gobini, but Gobini method is, I think, that's popular. And his resectoscopy is only 1.9 millimeter. And it has overcome the dilatation of the cervix, which sometimes becomes very difficult. Then we should dilate the cervix up to 6 to 7 millimeter, then we use the resectoscope, then we do the surgery. But in this case, we can use it at office hysteroscope, and the submucous myoma, polyps, and the other septoplasty he has shown, we can do it. So thank you very much for your excellent talk. And last of all, the HIFU. Actually, I think about 3 to 4 years back, one of the person from company, they asked me to buy this machine for our hospital, that is the OGSB, obstetrical and gynecological hospital. But it was so expensive, so that I didn't know we can't buy at this time, because we have no such money now at it. But I think for fibroid, I don't know what will be the ultimate result, but for adenomyosis, I think it will be a good option, because for adenomyosis we have no such ideal treatment. Sometimes the patient had to sacrifice her uterus for this disease. So I think HIFO, yeah, ultimately we will have it, because when the expense will be less, we can buy it. So thank you very much, all the three speakers, for the excellent talk. And I think also our juniors will be benefited with this talk. And also I thanks the organizers for selecting me for this special session, and also the healthcare pharmaceuticals for sponsoring. Thank you very much. Fardana.
Thank you, madam. Thank you for your wonderful remarks on this overall session. Now we are going to another chairperson, Professor T. Choudhury sir. He's our mentor of the mentors. He's our guide, our honorable professor. He's the president of Fertility and Sterility Society of Bangladesh, past president OGSB. Now I would like to request Professor T. Choudhury sir for his remark on this presentation. Professor T. Choudhury sir, over to you, sir.
Thank you, Dr. Sai Fardana. As a matter of fact, I think I have got very little to say. The presenters were so elaborate in their description. Their videos are excellent, and I think it hardly needs any more to comment or to ask for. Only thing is that I'm happy because the uterine cavity was, for last few decades, more or less neglected in the finding of pathologies, particularly in case of fertility and pregnancy loss. Now, with the interest in hysteroscopies, we are finding there are lots of pathologies we can encounter. And more important, that we are getting better and better technology for dealing with those abnormalities or pathologies without damaging the endometrium itself or without reducing the capacity of the uterine cavity. So I think their lecture has been very timely and it will stimulate our younger hysteroscopists just to go on with the procedure with their own intuition, their own ingenuity, and possibly we can serve our people by a very simple, non-invasive technique with lots of benefit. So I think this should be popularized, and thanks for bringing out a smaller and smaller and more effective equipment for this purpose. So thank you very much for guiding or giving a sort of impetus to our young hysteroscopists. About HIFU, I think one question I want to do, I want to ask is it repeatable?
Yes,
so
it is. It is repeatable.
It is repeatable. The cost, as he has said, that when people started with Da Vinci system, also people thought it was too expensive, but gradually the price is coming down. So as you said, and we also expect the price will come up, but this come down, but this is not equipment to be kept in individual hospitals. I think this country now afford a limited number of this type of equipment. They should be placed in the best institute where they can serve the best possible number of people. But more important is that the person's interest is the most important. So somebody who is genuinely interested to provide this service should be provided, if possible, with this equipment so that he can gain from his experience and possibly use this instrument to a better advantage. Maybe MRI guided may be a little cheaper, but I think ultrasound guided can also be equally effective, but depends on the person who will be operating. And it is not for general use, for use by particular person who has got a special interest. So thank you very much for bringing this equipment to Malaysia. And we know how difficult it is to get these things established, not only in Malaysia, but more so possibly in Bangladesh. But we hope that sooner or later it will be possible. We'll have this equipment in this country also. So thank you very much for giving us an idea.
Thank you, sir. Thank you very much for your clear message and beautiful remarks on overall presentation. Thank you, sir. Now we are at the end of the session. This is the time to say goodbye to everyone, and thank you very much. Before that, I will like to call upon Dr. Tarannum for a vote of thanks. Thanks, everyone. Dr. Tarannum, over to you.
Thanks a lot to our three eminent, wonderful speakers for their excellent presentation. We have enjoyed a lot and we have learned a lot, especially the video session of various techniques of hysteroscopic resection of the myoma and various advantages of mini laparoscope and types of HIFU. So thank you very much, Dr. Luigi, Dr. Gubini, and Dr. Silva. Special thanks to our honorable and respected chairperson, Dr. T. Chaudhary sir and Professor Laila Juban Banu ma'am for chairing this wonderful session. And also I'm thankful to our moderator who has conducted this session very successfully. Now we'll go for our next session, which will be on male infertility. So I have moved my chairs to the next rapporteur, but before going to the next session, we will watch a short video of healthcare pharmaceuticals. So thank you very much and Allah Hafiz.
Assalamu alaikum. Dr. Benazir Haq is here. I am working as an assistant professor, Anwar Khan Modern Medical College Hospital. So welcome to all in this session, which is especially focused on initial evaluation of male infertility and critical appraisal of test and advanced management of male infertility. We are very much delighted to have with us as a chair, Professor Sheikh Zinatara Nasrin Madam, Scientific Secretary, Ops Gynae Society Bangladesh, Secretary General, Bangladesh Menopause Society, Secretary General, PCOB, and Executive Member of FSSB. Next one chairperson is Professor Shahanara Chaudhary, Professor and former head of the department, Chittagong Medical College, ex-president, Ops Gynae Society, Bangladesh CTG branch, and organizing secretary, FSSB, also executive member of OGSB. So now I hand over to the moderator of this session, Dr. Sharmin Abbasi, Associate Professor, OBGYN, and Scientific Secretary of Endometriosis Society of Bangladesh. Over to Sharmin Abbasi.
Thank you, Dr. Benazir Haq, for the nice introduction, honorable chairperson, speakers, and the learned audience. It is my great privilege to invite you all in a very important session of 6th FSSB conference, which is focused on male infertility. In this session, we have 3 renowned speakers who will talk on different aspects of male infertility. Dear audience, recent research suggests that male factors contribute 60% to couples' infertility, and despite of high prevalence of 70 million men affected worldwide, but the majority of the new diagnostic and therapeutic approaches always focused on female infertility. So as a time demand to rethink about the male infertility, so I think this session will give answers of many unanswered questions on male infertility. Respected speakers, I am humbly requesting all of all to complete the session within the allocated 20 minutes so we can take more questions from the audience. Now I would like to invite our first speaker. Our first speaker is Dr. Thomas A. Masterson. Dr. Thomas A. Masterson, he is Assistant Professor of Urology in the University of Miami, Miller School of Medicine, and he is very enriched and had many achievements for the outstanding scientific contribution in the era of the male infertility. He is awarded the Fertility and Sterility Star Reviewer Award presented at ASRM, Travel Award to Endocrine Society meeting for Outstanding Abstract, and he is Sexual Medicine Society of North America Research Grant recipient, and also have many recognition for the outstanding contribution for the scientific activity. Please welcome Dr. Thomas A. Masterson. He will talk on initial evaluation of male infertility and critical appraisal of tests done for male infertility. Please welcome, sir.
All right, thank you very much. Pull up my slides here. Get it into presentation. All right, excellent. So I'm Dr. Thomas Masterson from the University of Miami in Miami, Florida. It's truly a pleasure to have been invited and to talk to you today. And we'll be covering many of the tests involved in male infertility and discussing when they should be used and what some of their limitations are. I have no relevant disclosures. So as with all fertility issues, it's going to start with a thorough reproductive history. With men specifically, we're looking at duration of infertility, whether it's primary versus secondary, any surgeries in the past that may be influencing them, medication use, radiation, chemotherapy, and so forth. Next is reproductive physical exam. And this focuses mostly on the scrotum, testicles, and what we're looking for, any abnormalities or signs that something may be going on. Things that may be picked up are, absence of the vas deferens, the presence of varicocele, epididymal tenderness suggesting obstruction or infection, and previous surgical scars that may be leading to an obstructive state. Guidelines suggest that we, in the first evaluation, get hormones, including testosterone and FSH. In my own practice, I also would add in LH and estradiol, as well as 17-OHP. Many of you may be familiar with 17-OHP in pediatric urology when screening for congenital adrenal hyperplasia. But work we did here at the University of Miami looked at 17-OHP as a marker of intratesticular testosterone. Why is this important? Well, in sperm production, testosterone is used for that last step of maturation. And while the testosterone levels in the serum may be normal, patients may not have normal intratesticular testosterone. So we actually will use this value, this number, to monitor whether patients may be taking exogenous testosterone, whether they're responding to therapies like HCG or Clomid, but also to screen for patients who may benefit the most. Traditionally, we would use medical therapy in men with low serum testosterone with lower sperm counts, but really it's the 17-OHP that is more reflective of response. And in our graph here, you can see the data that we presented that showed various 17-OHP levels in patients who were on medical management versus testosterone therapy. So semen analysis is truly the cornerstone of the male evaluation. It is recommended to get 2 because variability among semen analyses is quite high, as much as 80%. Looking at this graph from the WHO manual, we see different colored charts. These colors represent different patient populations. But what I want you to take away from this is what you're seeing are bell curves. This top line of black is men who had fathered a child in the past year who provided a semen analysis. So this was our fertile controls. Compare this to other unselected populations, you see some similarities. From this, the WHO created their normal values, which are the lower 5th percentile. And the important thing to take away from this is that semen analysis is really not a test of fertility, but a test of fertility potential. Even the men on the lowest end of these graphs still fathered a child within the past year. So unless the semen analysis shows 0 sperm, 0 motility, or very specific morphologies, we really can't say that a patient is infertile. So speaking of men with 0 motility, or 0 concentration or azoospermia, in men with very low sperm counts, or what we call severe oligospermia, counts less than 5 million, it's recommended to get genetic testing in the form of Y chromosome microdeletions and karyotypes. And the reason is that these genetic abnormalities are more common in men with severe oligospermia or azoospermia. But when we actually look to see when should we be ordering this test, despite the recommendation of getting these testing with concentrations less than 5 million, the incidence is really only highest in azoospermia. So in a cost analysis, where in my practice, I have 2 groups of patients, those that are insured where these tests are covered and those who are uninsured where they're paying out of pocket, I will actually, after discussing with the patient, not order these tests until I see a concentration of 2 million or less. And that's because the incidence of seeing these mutations at concentrations greater than actually 1 million are very low. If you use 5 million as a cutoff, the sort of cost to the healthcare system is almost 5 times as much to detect one abnormality. Now, imaging is heavily used on the female side of fertility workup, but on the male side, imaging is not as much a critical part. Scrotal ultrasound is something that many men will already come in with, but I actually do not order these unless I encounter a scrotal mass or a difficult physical exam. So this is typically men who are heavier set, very muscular scrotum, and I may be looking for varicoceles or testicular abnormalities. But scrotal ultrasound is not good at identifying absence of the vas. And when it comes to detecting varicoceles, varicocele is a clinical diagnosis, and the grading system is presented here. But adding to confusion in the literature is that in radiology literature looking at varicoceles, multiple cutoffs have been used as a detection of varicocele. What we use at our institution, and that what is most widely used, is 3 millimeters. And I truly do look for reversal of flow before I consider trying to repair one. Transrectal ultrasound, again, not used all that commonly, but we do use this for the diagnosis and evaluation of situations like ejaculatory duct obstruction. This is suspected when we have acidic pH with a low volume. This can also be can be used in partial ejaculatory duct obstruction. This is situations where we may see a normal concentration with abnormally low motility, meaning motility is less than 20%. On transrectal ultrasound, what we're looking for is dilation of the seminal vesicles in a post-ejaculatory sample. So we have the patients actually provide a sample that morning and then do their ultrasound. But the diagnosis is ultimately confirmed with seminal vesicle aspiration. And what I mean is there should not be sperm in the seminal vesicles in a normal patient. Someone who's obstructed, there may be. So even despite this size cutoff, we do recommend still performing aspiration to confirm the diagnosis. All right, so now we'll be moving into some of the advanced sperm testing. We'll be looking at specifically DNA fragmentation, sperm aneuploidy, and sperm antibody testing. So what is sperm DNA fragmentation? Well, as sperm matures, it encounters some of the immune system, but it encounters insults that may cause damage to the DNA. And this is in the form of single and double strand breaks. DNA fragmentation should be suspected in patients who have recurrent pregnancy loss, recurrent IVF failure, and questionably, we order this in patients with varicoceles. We'll cover the 4 main tests in the next 4 slides. So the first test is the sperm chromatin structure assay, or SCSA. And this is considered the standard in testing for DNA fragmentation due to a protocol that is replicatable, but also provides consistent results. This uses acid denaturation of the sperm, which then stains the DNA, and the sperm are then put through flow cytometry. The sperm is then, the dye is then excited and will either fluoresce orange or green, and it will give you a readout as a percentage of sperm that have DNA fragmentation. This can also provide information on DNA satiability, and it is, again, questionable that these are immature sperm. So when you actually do the testing, this is the type of readout you get. It's a histogram, but it's interpreted for you. And it will give you a readout as the percentage of sperm that carry DNA fragmentation, or HDS. The next test that we'll cover is the sperm chromatin dispersion test. And what's happening in this is, again, the sperm is being denatured, but unlike being interpreted by a machine, what's happening is the sperm is creating halo loops of the DNA that's contained. Looking at the panel here on the right-hand side, on panel A, this is normal sperm where we expect the DNA to loop out, whereas D is very condensed, and this is considered high DNA fragmentation. Next is the tunnel assay, where the 3-hydroxyl end of the DNA is actually going to be labeled and again put through flow cytometry. Areas that are damaged will fluoresce, and this is picked up with a camera. And then again, it's reported as a percentage of the DNA that was fragmented. This will stain both single and double strand breaks. However, it is not typically reported. And lastly is the sperm comet assay. Again, the sperm is placed into, in this case, an alkaline pH, and this results in unwinding of the double strands. The sperm is then put on in an electrophoresis grid, and the strands are migrating towards the anode. The longer the tail, the more DNA fragmentation that's contained. When 2 anodes are used, you can potentially distinguish between single and double strand breaks. So why do I keep harping on single and double strand breaks? Well, Part of the theory of DNA fragmentation and why it causes problems is that higher levels of fragmentation may lead to infertility, but specifically the double strand breaks may be more impactful because the ovum may be able to overcome single strand breaks with repair mechanisms. So when now looking at comparison of these methods, in this study, the authors were looking at infertile men and assessing these DNA fragmentation tests for sensitivity and specificity. And what you see is that while the tests are fairly specific, they may not be very sensitive. And then when comparing cutoff values between the tests, what we see is there's a substantial difference between the percentage of DNA fragmentation being detected and infertility. So this leads to some problems. Concerns with DNA fragmentation testing are that there's no absolute cutoff value that leads to fertility. While the labs may represent 20, 30%, just because somebody is over 30% does not make them infertile, just as if they're under 20% doesn't make them fertile. There's an inability of these tests to truly differentiate between these single and double strand breaks. So most do not report, and if they do, it's hard to provide accuracy. They're also highly variable. So when a patient provides a sample, and if you are to send them to different tests or to different labs to do testing, you will get very different results. Simultaneously, that same sample run multiple times may also give you different results. And lastly, it's still unclear as to whether DNA fragmentation is a primary cause of infertility. It may affect natural conception more so than it does IVF and ICSI. So sperm aneuploidy testing, when sperm are dividing in meiosis 1 and 2, there can be non-disjunction events. And what this leads to is sperm carrying an abnormal number of chromosomes. And while this may not be lethal to the sperm, these may be non-viable with life. So after fertilization, the eggs or the embryo may not progress or the pregnancy may terminate. Indications for ordering aneuploidy testing is recurrent IVF failure, recurrent pregnancy loss, and implantation failure. Now, the chromosomes being tested vary substantially between laboratories, but most will test for 13, 18, 21, X, and Y, because these are viable with life. An issue that's happened over the past 5 years is that it's become very difficult to identify labs that actually perform this testing. So even at our institution, we've had substantial difficulty in now contracting as to who will actually perform this testing. And in the past 6 months, we've actually not even been able to order it. So that's become a real problem if this is a suspected cause of infertility. And lastly, we'll discuss anti-sperm antibody testing. So anti-sperm antibodies are antibodies against sperm, and these can be produced in the seminal fluid or vaginal fluid. We will order this when we see men who have abnormal agglutination or low sperm motility. So men that have maybe normal counts, but the motility is bad or progressive motility is bad. This typically is suspected in men who've had prior scrotal trauma or prior scrotal surgery, because the testicle exists in an immune privileged site, and normally the sperm should not be exposed to the immune system. These can be tested, or anti-sperm antibodies can be tested in serum, seminal, and vaginal fluids, and we're looking mostly for IgG and IgA. There are direct and indirect tests. Direct tests are when we actually look for the antibodies direct on the sperm already, and versus indirect is where we check the actual fluids. And just like with the other sperm test, the results can be highly variable between labs and even within the same patient. And lastly, the impact of anti-sperm antibodies remains unclear. It's well established that men undergoing vasectomy or reversals have high levels of anti-sperm antibodies. However, this doesn't always impact reproduction. So in summary, the male infertility evaluation consists of a thorough history and physical, 2 semen tests, and at least a testosterone and FSH. 17-OHP is a marker for intratesticular testosterone. Imaging is not a routine part of the male evaluation. And lastly, DFI and really all advanced sperm testing is highly variable and should only be interpreted within the clinical context. So I thank you very much for your time. It's truly an honor to have been invited to this presentation, and I'll be happy to take any questions at the end.
Thank you very much. Thank you, Thomas Masterson, for your wonderful presentation, sir. And you perfectly judge on your title regarding the evaluation of the main infertility and the management before aspect, that is the evaluation and testing aspect. And you perfectly took importance about the different aspect of sperm and semen analysis also, and linked with IVF failure and also the recurrent pregnancy loss, which is also sometimes the new theory to the new or young doctors. Thank you very much. And we have many questions for you. If the time permits after the 3 presentation, then we can take the question. Thank you again.
My pleasure.
Ladies and gentlemen, I'm now going for the next speaker. Our second speaker is Dr. Tanzim Sabina Chaudhry. Dr. Tanzim Sabina Chaudhry is a renowned academician and also the clinician both, and she is currently working as Associate Professor of Department of OBGYN in Ibrahim Medical College and Bardim General Hospital. She is Executive Member of Fertility and Sterility Society of Bangladesh, Organizing Secretary of Endometriosis Adenomyosis Society of Bangladesh, PCOB, and Fertility Preservation Society of Bangladesh. Author of a chapter of Age and Infertility in Practical Guide in Infertility. She will talk on a very important topic, that is the treatment of the subfertile man, how to approach. Please welcome Dr. Tanzim Sabina Chaudhry for your presentation.
Thank you, Dr. Sharmeen, for this very kind introduction. Okay. Very kind introduction, and thank you to the Scientific Committee of FSSB to give this opportunity to me to talk on this prestigious session. Today, I'm going to talk about treatment of subfertile men, how to approach. Mostly what I'm going to talk about is about the medical treatment that is available and what can we do to treat a case of male infertility. I have no actual or potential conflict of interest in relation to this program or presentation. So my presentation will include the causes that can lead to development of infertility in men, what are the medical treatments that are available, what are the empirical treatments we give, and is there any evidence to use empirical treatment? What are the unproven therapies, the practices that we need to abandon, and then we'll summarize everything. So let us come back to male infertility. We know that at least in 1/3 of the couples of infertility, a male factor is identified along with a female factor. And even though different studies show different results, at least 10% of the infertile couple, only there's a male factor, which is the identifiable cause. So we cannot actually ignore male partners when we talk about the female partners. And actually the general principle is that we have to do the treatment of concurrent male and female infertility. We have to remember that there might be some mild male factor infertility, which can be compensated by the treatment of the female partner as well. So it's very important that we address the problem of infertility as a couple, and we have to do concurrent investigation and evaluation and treatment of both male and female partner simultaneously. So let us start with the male partner. If you want to see the causes which might lead to the development of male infertility, it can be broadly divided into 4 types. One is the endocrine and systemic disorder, in which hypogonadotropic hypo is very important because it has a very effective medical management. Then there's a primary testicular defect, which is hypergonadotropic hypogonadism. There may be sperm transport disorder. And also there's another group called idiopathic male infertility. Actually, idiopathic male infertility actually is an infertile man who has an abnormal semen analysis, but there's no apparent cause of infertility. So let us start with the hypo-hypo. So hypo is important because this is one of the few medically treatable causes of male infertility, which can be primary, which can be secondary. And whenever there's a secondary hypo, you can see in this picture, there's a low concentration of all the hormones, the FSH, LH, and testosterone level. On the other hand, if there's a testicular defect, usually the testosterone level is low, but there's a high rise of FSH, LH, and GnRH. We all know about the negative feedback mechanism. Now, in these patients of hypo, fertility can be restored using either GnRH or exogenous gonadotropin. Now, we all know that the best replacement therapy would be pulsatile GnRH administration, but it has to be given in a pump, which is costly and it causes discomfort to the patient. So more or less, pulsatile GnRH is not used practically in day-to-day practice. What we can use is a use of exogenous gonadotropin, which is the second best thing for the successful treatment of a hypo case. In that case, it has been seen by different studies that spermatogenesis can be efficiently restored by HCG alone as a replacement of LH or in combination with FSH. But the problem is the optimum protocol, the timing, and the dose for this treatment is controversial. If you look at this long list, we can say these are all big clinical trials, and they have all used FSH regimen in hypo, and they have all had good results. But you can see some used urinary FSH, some use recombinant FSH, some use 75, some use 150. So even though we know that FSH and HCG both work fantastically in case of hypo, we still do not know what would be the optimum regimen. This study in andrology showed that gonadotropin stimulation was beneficial in about 75% of the cases, and they obtained a final sperm concentration about 6 million. Now, these 6 million may be sub-physiological, but they were able to obtain a pregnancy through ART. So there is actually a beneficial synergistic action of HCG-induced testosterone, which can restore fertility despite suboptimum sperm parameters. Another cause of hypo is hyperprolactinemia, which is a cause of secondary hypo. So if there's a hypo, we can check the prolactin level of this male. And if there's a hyperprolactinemia, we can cause discontinuation of the medicine that is causing the hyperprolactinemia, or we can give cabergoline or bromocriptine, or if it's a macroadenoma, there may be need for surgery. We have to remember that by giving bromocriptine or cabergoline, if the serum prolactin level comes to normal, but the testosterone level does not come to normal, there may be a need for gonadotropin treatment as well, along with cabergoline and bromocriptine in those patients with hyperprolactinemia-induced hypo. Second cause that we get is primary testicular defect, where we get low level of testosterone and high level of FSH and LH. Unfortunately, there is not very known effective medical therapy for these group of patients. There are success rate with assisted reproductive technologies, but we have to know that it depends on how much testicular damage has been done. And sometimes the success rate is quite low if we compare men with other infertility diagnoses, and there may be a need for sperm donation if it is allowed. Third group that we get to see is sperm transport disorder. It may be because of sexual problem like infrequent vaginal sexual intercourse, erectile and ejaculatory disorder. Among all these factors, the one thing that has some amount of medical treatment is retrograde ejaculation. There are medical treatment for sexual dysfunction as well, but which is beyond the capacity of this presentation. So there may be treatment for retrograde ejaculation, but if there's an obstruction in the epididymis or ejaculatory duct, then in this case, most of the cases, the treatment is ART, and sometimes there may be a treatment by surgical treatment as well. I'll come to it later on. So in case of retrograde ejaculation, there are several things that has been tried and still tried nowadays. There may be urinary sperm retrieval followed by ART, medical management with anticholinergic and sympathomimetic, surgical techniques, and electroejaculation. But current literature is insufficient to allow firm comparison between different interventions. So we have to individualize the patient, and I think we should use our judgment to do what can be done and what is best for the patient. So if you want to know about more pharmacological agents for retrograde ejaculation, there was a recent study where they used pseudoephedrine regimen prior to ejaculation, and they showed very good result with it. They showed that about 70% patient had improvement of seminal parameter, and about 40% of them actually had antegrade total sperm count of about 39 million. So this is promising. We can use this to treat a patient with retrograde ejaculation. And in case of obstructive azoospermia, as I said before, there's no role of any medical treatment. It's either surgery or ART. And I'm sure Dr. Rupin Shah, the next speaker, will talk a lot about it. And there are different types of surgeries present: vasovasostomy, vasoepididymostomy, reversal of vasectomy, etc. But we have to know that the result is variable, because the result depends on a lot of things: the site of the obstruction, the duration of the obstruction. If there's a prolonged duration, then there may be poor result. And most importantly, the experience and the skill of the operator. So we have to judge a lot of things before deciding whether the patient should go for surgery or ART. Now let us come to the last component, which is the idiopathic male infertility. Now this is the controversial one, because we get to use a lot of things for idiopathic male infertility without knowing which one will work better. So at first, we usually give some advice to the male partners, like if he's obese, we tell them to lose weight, increase physical activity, cessation of smoking, avoiding tobacco and alcohol, etc. Even though all these things are good habits and they actually increases the normal health status of the male partner, but there is not enough study to show that if weight reduction and smoking can actually increase the cessation of smoking can actually increase the semen parameter. And there has been a hot topic recently, a few years back, actually, about scrotal heat. They said that if a man wears a tight underpant, or he uses hot bath and sauna, or a prolonged laptop on his lap, can lead to infertility. But now it has been seen that there's not enough evidence that avoiding all this can increase sperm parameter. So we can actually give this lifestyle advice, but there's not much strong evidence, and further studies are required. Now the empirical non-hormonal therapy, we are all using it every day. These are the oral antioxidants. Oral antioxidants are the most commonly adopted empirical medical therapy, which are the substances that inhibit or delay the oxidation of biologically relevant molecules. Now, there are thousands of, I think hundreds and thousands of products in the market, which has only one antioxidant, or most of them has a combination of antioxidants. Now, there are substances which has direct antioxidant capability, like carnitine and carotenoid and cysteine, coenzyme Q10. And there are other products which have antioxidant properties, like myoinositol. These are actually available in the market, and we use it for idiopathic male factor infertility. But does it work? So there was actually a systemic review in the Cochrane Library in 2019. They actually reviewed meta-analysis of about 61 RCT, and they found that if a combination of antioxidant is given, but it can cause improvement in the proportion of clinical pregnancy and live birth, but the quality of evidence is low. So if you look at the table, you can see that, yes, there is increase in the live birth rate per couple randomized, clinical pregnancy rate per couple randomized, but the certainty of the evidence is low. So further large, well-designed, randomized, placebo-controlled trials are required to exactly find out whether antioxidants actually work to increase the pregnancy as live birth rate. We still do not know. There's one product which has been, there is one product which has been used nowadays, almost all of us use it, is coenzyme QA. It also, there are many studies on it, and it also shows that use of exogenous administration of coenzyme Q10 can actually increase the level of its own coenzyme as well as ubiquinolone in the semen, and it actually is effective in improving the sperm kinetic feature of the patient. But studies also show that even though it increases the sperm kinetic feature, there's no evidence in the literature that it can increase the live birth rate or pregnancy rate. So even though there might be an improvement in the sperm parameter, we still do not know whether it will increase the live birth rate, which is the ultimate evidence of fertility. Now let us come to the empirical hormonal treatments. We can start with clomiphene citrate. Clomiphene citrate actually blocks the negative feedback to hypothalamus and pituitary. As a result, it causes mild or moderate elevation of the FSH, LH, sperm concentration, and in some studies, they say even the pregnancy rate. But there are studies that show that clomiphene citrate may work in those idiopathic infertility with a special, which have a sperm concentration of 10 to 20 million with low FSH, LH, and also there is normal or slightly below normal motility and morphology. They can actually attain a sperm concentration, which is actually make them viable candidate for artificial insemination. So we cannot say the CC will work for everybody. We have to actually individualize the patient. Those with a low FSH, LH and a moderate type of oligospermia can actually benefit from that so that they can go for IUI. Aromatase inhibitors have been used. It prevents the peripheral conversion of testosterone to estrogen. As a result, there is increased testosterone leading to increased FSH and spermatogenesis. It can work in men who has abnormal testosterone estrogen ratio. Letrozole is the most important one. So it can cause modest improvement of testosterone, estrogen, and sperm parameter. Salam in his study has shown that those men with low testosterone can actually be given letrozole, and he has shown that there is increase in the serum testosterone, sperm concentration, motility, and morphology. And according to his study, 2 of the 10 oligospermic patients conceived, while 4 of the 70 azoospermic had return of sperm in their ejaculate after treatment. Another hormone that has been used is gonadotropin. I have already told gonadotropin is highly effective if the man has hypo. But if it's idiopathic infertility, studies show there's a higher pregnancy rate than placebo, but actually the treatment protocols were variable and the quality of evidence was low. So if you summarize all the empirical hormonal therapy, we'll see that even though some of the data actually show that clomiphene can improve the sperm parameter and the hormone level, the evidence is not strong enough. So it is mostly used off-label and still is not recommended for male infertility. Data for aromatase inhibitor are also restricted to case reports, which are really small, low-quality studies. So still, letrozole is not used for the treatment or not recommended to be used for male infertility. Gonadotropin has a very good value if patient has hypo, but in case of idiopathic infertility, it has very limited role. And lastly, testosterone. I've read it in red because everybody should know that exogenous testosterone should not be used for male infertility treatments because it inhibits spermatogenesis. So these are the empirical treatments that we use. What are the other therapies we use that should not be used and abandoned? Leucospermia, we get to see a lot of men with semen analysis where they show high count of WBC. And these are mostly due to the effect of a chronic prostatitis. And when culture is done, most of the time, no organism is identified. So antibiotic therapy is not recommended. Chlamydia infection is another controversial issue. The effect of chlamydia infection on semen quality and infertility is controversial. And it has seen that prescribing antibiotic to combat chlamydia infection has actually no evidence. NSID, a lot of people have said that there's increased reactive oxidative species, and they suggested NSID or mast cell blocker to improve sperm quality, but efficacy of short-term NSID is unproven. Lastly, this is not part of my lecture, but I think we cannot forget assisted reproductive technology when we talk about male infertility. There are 2 components, one is IUI and IVF with ICSI. In a 2016 systemic review concluded that the overall effectiveness of IUI for male infertility is inconclusive. That means if it's a true male infertility, then IVF with ICSI is the effective treatment. IUI can be suggested in men with mild to moderate sperm abnormalities, but there is actually, in a randomized control study, they showed there's actually not much of difference between natural trying and IUI in case of mild sperm abnormality. So the treatment of choice for male infertility is IVF with ICSI. We all know that. So in those patients with severe OATS and non-obstructive azoospermia, can try for that, even for obstructive azoospermia as well. But we have to know that if it's a primary testicular failure, the outcome may be lesser than those who are going for IVF with normal zoospermia. So if you summarize lastly, these are the 4 categories I started with. And if you look at their treatment, we can see that those men with hypogonadotropic hypogonadism actually has the highest efficacy rate if they're treated medically with HCG, with or without FSH. In case of primary testicular failure, there is unfortunately no medical treatment. ART can be tried with their own sperm or sperm donation. Sperm transport defect, there's no medical treatment except maybe retrograde ejaculation. In that case, either they should go for surgery or ART. And last, idiopathic OATS. We do not know which one actually works best. Some of them work, some of them don't, and the response is not very strong according to the evidence. So a lot of things has been used. So some use CC, some use aromatase inhibitor, HCG, antioxidant, etc. So we have to use our logic and use these substances judicially and actually select the patients and be selective and actually make the treatment individually as far as possible. So my take-home message is that male and female partners should be treated as a couple. Role of medical treatment is limited in male infertility and should be used judiciously and logically. Lifestyle changes are important. They should be given emphasis to, especially obesity and cessation of smoking. Empirical treatment can be prescribed in idiopathic male infertility, but we should also think about the cost-benefit ratio. And last of all, testosterone should not be recommended in any male infertility protocol. Thank you very much.
Thank you. Thank you, Dr. Tanzim Sabina Chaudhary, for your excellent and elaborate presentation. Madam, you perfectly judged your topic, your title, and you started from the lifestyle modification and cover up to the ART. And there are some big questions and big question mark you just put in your presentation today. That is when we should give cabergoline, yes or no, when we should give the antibiotic in chlamydal infection and also leucospermia. The common thought of the people, we need to prescribe the antibiotic. So it's a big question in the mind of all the participants. From tomorrow, do you start to use it or do you not start to use it? Thank you very much for your elaborate presentation. We have many questions in our hand. If we can get time, we will take all the questions for you. Thank you again.
Thank you.
Ladies and gentlemen, now I'm going to the last speaker of today's session. Our last speaker, Dr. Rupin Shah. Dr. Rupin Shah doesn't need any introduction when we are talking about the surgical aspects of male infertility, because in the subcontinent, he is a legendary surgeon for dealing with the male infertility. He is the consultant andrologist and microsurgeon, Lilavati Hospital and Research Center, Mumbai. He is specialized in microsurgical reconstruction for male infertility, sperm retrieval in azoospermia, surgery for penile prosthesis, and developer of the Shah penile prosthesis, and founder president South Asian Society for Sexual Medicine, published and presented over 100 papers and 26 book chapters, associate editor of the Fertility and Reproduction. Please welcome Dr. Rupin Shah, sir. He will talk on very time-demanding topic because many of we have questions regarding this issue, that is the obstructive azoospermia, bypass surgery or ICSI, which should be suitable for. Please welcome, sir.
Thank you, Dr. Sharbin, for that warm introduction. And I would like to thank all the organizers, Dr. Maruf and others, for inviting me to be part of this wonderful meeting. It has been so well organized, from the communications, the brochure, the little video showing all the speakers. And I judge a meeting very often by, as a faculty, how often do I get a communication? Am I struggling to find out what's happening? And here it was the opposite. There was so much information up to date that I knew it's going to be a great meeting. And today's session has been wonderful. Dr. Tanzim, excellent overview of the medical management. I really enjoyed it. And Dr. Thomas shed some very important light on the subject of sperm DNA fragmentation, which is a very hot topic and very controversial. So we've had some wonderful talks, and I'm now going to come to something that's a little tricky because it deals with a subject that all of us are interested in, but really very often we don't have access to all the options. So as Dr. Tanzim mentioned, one of the three things, you have pre-testicular, testicular, post-testicular. So the third problem is obstructive azoospermia. I'm not so much talking about vasectomy reversal here as obstruction in the epididymis. So basically what we're talking about is a patient who has normal spermatogenesis in the testes, either judged clinically or proven by FNAC or biopsy, and who has a block in the epididymis. It could be in the vas also following vasectomy, but say he has a block in the epididymis, therefore he is azoospermic. And the big question is, how should we treat him? We have two options. We can retrieve sperm from the epididymis quite easily and use those sperm for ICSI, or we can refer the patient for reconstructive microsurgery. And before I continue, can someone from the audience just confirm that I'm heard and seen clearly?
Yes, we can.
Yes, we can
Thank
see
you,
you.
because I've had occasions where I've gone on speaking and either I've forgotten to share slide or I'm not heard. Thank you. So we have the query, and the tendency, of course, is to push the patient into sperm aspiration and ICSI for two reasons. One, that is very easy, and two, that is widely available. So the purpose of the talk today is identify what is better for the patient. Sometimes what we offer may not be what is best. It may depend on what is available, but at least let us be clear about what should be the goal. So here is a simple technique of aspirating sperm from the epididymis. You can see that the head of the epididymis has been stabilized between the thumb and the forefinger, and a small 26 gauge tuberculin syringe needle is used to puncture the head, and suction is applied with this syringe. You don't need special equipment. You don't need microsurgical. You don't need a large needle. A 26 gauge needle punctures the epididymis and is very slowly moved through the head, through the tubules, puncturing them, giving time for the fluid to be aspirated into the syringe. Sometimes you see fluid, sometimes you don't see fluid because it may be thin and transparent. So there is 0.1 ml of medium in the syringe and a slow aspiration through the head. And then we withdraw the syringe and check for sperm. So since this is a blind procedure, sometimes you may have to make 2, 3, 4, 5 punctures before you get motile sperm. But by and large, it's a highly successful technique done within a few minutes under local anesthesia without the need for anything microsurgical, and you get enough sperm for the ICSI and for future freezing. So this is what most IVF centers would offer. If you don't have an andrologist, you may not do PISA, you may do TISA, which is equally effective in finding sperm and producing a pregnancy. But what about the alternative? Should a vasoepididymal anastomosis be advised? Would that be better for the patient? So should we join the vas to the epididymis, bypassing the block so that sperm can come out naturally? So let me first explain how this procedure has evolved, because many of you may have been exposed to the older conventional VA and seen very poor results. So let us understand the difference between the conventional and the microsurgical VA. The epididymal tubule is a very tiny tubule, 0.2 to 0.3 millimeters in diameter. And when you're not using microsurgical magnification, the tubule is too tiny to be operated upon. So what was done in the olden days was a slit was made through the epididymis, cutting through the tunica, cutting through the underlying tubules. The vase was also split open, and the muscle of it was sutured to the tunica of the epididymis. So effectively, you didn't have a true anastomosis. This was more a fistula technique, where the vase and the epididymis were brought together, and it was hoped that sperm leaking from the cut tubule would find its way into the lumen of the vase, which worked sometimes, but quite often it failed. Then in 1978, Sherman Silber suggested that if you use an operating microscope, you could actually anastomose the mucosa of the vase to the epididymal ductule. The technique that he suggested was an end-to-end anastomosis, which has many technical difficulties and was soon replaced the end of the vase was anastomosed to the side hole in the epididymal ductule. And that was true anastomosis, where there was true luminal and mucosal continuity. So if you look at this through a few pictures, this is magnified 25 times. You can see the epididymal ductule. A small opening is made in the tunica. The ductule is mobilized and a side hole is made in the ductule. And then using a very fine 1770 micron needle and 10-0 ethylon, the blue stained mucosa of the vase is anastomosed to the blue stained mucosa of the very transparent and thin epididymal ductule. So you can appreciate that this is a truly delicate procedure. Where the cursor is, you can see that's the transparent epididymal ductule. Here is the vase, and that is the completed anastomosis. And then the muscle of the vase will be anastomosed to the tunica of the epididymis to complete the anastomosis. Very neat technique, but very demanding, and very few people could do it. Then Marmer came up in 1990 in 2000 with a much easier technique in which two double-arm sutures were taken, two needles were placed in the ductule before it was opened, and then an opening was made between the two needles. So this was very easy because the needle was before the ductule was opened and before it collapsed. And the end result was, as you can see here, there is a central opening barely visible that is opening, and you see two loops of sutures on either side. And when we pull the loop, you can see the ductule being lifted. So there are two sutures, 4 needles. These 4 needles will then pass inside out through the vase. And when they're tied, you can see here the ductule is actually pulled into the lumen of the vase. So the ductule intercepts inside. This is much easier than the previous technique and has quite a success rate. In Marmer's original paper, 7 of 9 men succeeded. In our own experience and that of many other published papers worldwide, the patency rate is 60 to 70%, and about half of them, so 25 to 30%, achieve a natural pregnancy. So this is a technique which is doable. And I have many students now who have learned this without the extensive microsurgical training that I underwent, and who are able to implement these procedures themselves. So which of the two options is ideal? Well, an ideal treatment would be one which is most effective, least more expensive, most natural. So if we compare cost of a vasoepididymal anastomosis in a general ward, doing almost free in some of the government hospitals, and even in a private hospital, it may cost 30 to 40,000 Indian rupees. And even if we did a bilateral microsurgery in a semi-private private room, it is still about 200,000 Indian rupees. By contrast, an IVF-ICSI program would cost significantly much more per attempt. If the VA succeeds, it results in a natural pregnancy, and that is something whose value we should not undermine, whereas ICSI, though successful and very rewarding, is ultimately an artificial outcome. Then when we look at morbidity, VA is treating the person who is at fault, which is the husband. ICSI is subjecting the wife who is normal to a major procedure for a fault in the husband. VA is very safe procedure. Test easily accessed, there's no morbidity. It's a daycare procedure, no pain. Man is back to work the next day. ICSI has been refined a great deal, but still, despite the best intentions, OHSS, multiple pregnancies with their attendant complications cannot be entirely avoided. So if you were to summarize pros and cons, vasoepididymal anastomosis, and the same holds true for vasovasal anastomosis, is a daycare procedure, very safe. There's no morbidity really, you're just cutting the scrotal skin. 2 out of 3 procedures should succeed on average, with half of them achieving a natural pregnancy. It's a lot less expensive, and if it succeeds, well, the second, third, fourth, fifth child are free. You don't have to repeat the surgery. And it does allow you to freeze sperm at the same time, so that after the VA, if the couple doesn't want to wait, they could undergo ICSI simultaneously. The advantage of sperm aspiration in ICSI is that it gives a much quicker result. It'll take 16 months after VA, whereas after IVF ICSI in 2 weeks, you know whether it's succeeded or not. There's no surgery involved for the male. Some men are very scared to be operated. And it has a live birth rate which may be a little higher than that which is achieved after a reconstructive surgery. It is, of course, more expensive, and you have to pay for each child. So if you were to then look at it, it would seem that VEA is the preferred option if you consider all modalities, which doesn't mean that there is no role for ICSI. If a VEA has failed, certainly ICSI is an option. And there are special situations where IVF ICSI may be a better option. As I said, VE often takes a long time for sperm to appear and for pregnancy. And hence, if the couple is elderly, AMH is low, there's a chance of ovulation failure, or the couple is really desperate. They've already waited 10 years, they're in a hurry, then ICSI may be the preferred option. Though I've had couples who had the ICSI, but also came for a VA later on, saying that we've done the IVF to get a quick pregnancy, but we would like it if the second pregnancy could be natural. Now, if a VA is required for someone who has an obstruction due to filariasis or tuberculosis, or has had hydrocele, here there's a huge amount of fibrosis. The success rate is much lower, and we are more inclined to suggest IVF ICSI. Similarly, when we examine the patient, only the head is palpable and body and tail are fibrosed, the chance of pregnancy is lower. We've had pregnancies and successes, but we are more inclined to suggest IVF ICSI. And this is a major point. Microsurgical VA, very high success rate, but it is a demanding technique. And unfortunately, in most cities, there'll be 20, 30, 40 IVF centers and not one trained microsurgeon. And truly, I think that is a limiting factor in recommending microsurgical VA. However, is it the best technique? So this is a real email I received. In fact, I prepared this talk for the Aspire meeting, which I was giving in March 2019. And exactly 1 month before, as I was sitting down to prepare the talk, I received this email, and I'm going to read it out. It says, Dr. Rupin, I was a patient of azoospermia. I met you in 2017. In March 2018, my VEA. 6 months later, my count was normal. Motility was 10%. At 8 months, motility was 15%. And now I'm happy to inform you my wife is having a normal pregnancy. Now read the next part. That is important because it's something that IVF centers often forget. Sir, I'm really thankful for the surgery. When I met you the first time, you told me all the doctors in Mumbai and told me VEA will not help, but you did it successfully, and I really thank you from the bottom of my heart. The message I want to give here is not that my microsurgery is great, but that every man deserves a chance to father his own child naturally. Men and couples will accept IVF ICSI if they see there is no option. But each one of them has told me, Doc, is it possible to do it naturally? A man's ego, his sense of self-worth, the couple's own desire is always towards a natural conception if possible, with IVF ICSI being opted for if the natural pregnancy is not possible. So to summarize, what is better, if you have the facilities and the trained surgeon, I think VA is better as the first choice. You can compromise by aspirating and saving sperm at the same time. And if the patient can afford it, they can do the VA, also do the IVF-ICSI, and then once you prove that the VA has succeeded, they can await a natural pregnancy. So thank you once again for inviting me to be part of this wonderful meeting. It's been a pleasure.
Thank you, Dr. Rupin Shah, for your wonderful presentation and very technical surgical aspects and microsurgical aspects when we are dealing with the cases of the azoospermia. It's really heart-touching, and the last word is really heart-touching to all of us. All the men just want to naturally to become father. So you just work on it, you try to give them hope. How can the natural pregnancy can occur in this type of cases? Again, thank you very much for the nice talk. Now I have time. Yes, I have time. I have 10 minutes time, so I will take some questions. First of all, I will go to our first speaker, Dr. Thomas Masterson. There are many questions for you. Just I can take one or two questions for you. One question for you, sir. You were talking about the sperm aneuploidy, and you tell that it may relate it with the recurrent implantation failure. So would you please explain how it's related?
Yeah, so the theory with aneuploidy is that the sperm aneuploidy, meaning an abnormal number of chromosomes, whether that's in full or in total, so full chromosomes being rearranged inappropriately, that they can still fertilize, and that in those first several days of embryo development, it may not be a lethal mutation, but when you go to transfer, it may either not take up root, or it may implant briefly, but then terminate to basically to early miscarriage. The biggest problem, though, with aneuploidy is it is, in addition to being difficult to test, there is no solution to it. If a patient has high DNA aneuploidy, then we're talking about donor sperm, and which is usually not the answers that patients want.
Thank you. I think the answer we will get. And just one question, small answer I just want from you. Interesting question that talk about the young Klinefelter syndrome when this type of cases come to us during the evaluation that you already talked or testing. What is the important topic it needs to cover? And with this, another question, anyone saying to us that is the sometimes we need to collect the pre-pubertal sperm. And at that time, we need to wait for the maturity. But is there any correlation in here? Dr. Thomas?
Oh, sorry. Sorry, I thought the question was directed to the second speaker. But so Klinefelter's is a very interesting situation. And we've done a lot of work on this patient group. The traditional thinking on them is that about 10% of them may produce some sperm in the ejaculate, and that we should, from puberty onward, be checking them almost yearly for sperm. But we've shown in sort of our institution, we've never really found sperm in a Klinefelter's patient. And there's also been thoughts that we should be taking almost pubertal testis tissue and freezing it in the hopes that later we can do something with it. We've also sort of done away with that practice. And what we're doing now is we're just medically managing the patients, trying to avoid testosterone use. So using anastrozole, clomiphene citrate, HCG if possible, trying to keep testosterone levels up above like 300. And then when that person is ready for having a child, we will then more aggressively treat them. And many of them go on to, I would say all of them go on to microtesy to look for sperm.
Thank you. Thank you, Dr. Thomas Masterson, for your wonderful answer. And sir, you are taking very trouble. It's early morning in your country for joining with us. Thank you. Thank you very much. I'm just taking one question for Dr. Tanzim Sabina Chaudhry, madam. Madam, that is the when we are tackling or treating the male infertility cases, some male have the autoimmune diseases. So autoimmune disease treatment can hamper the treatment of the male infertility or badly impact on male fertility.
Yes, thank you, Sharmin. Actually, autoimmune diseases comprise a lot of more than 80 types of autoimmune diseases are there. Some are even worse than the others, like multiple sclerosis or type 1 diabetes. And in these cases, if you start therapy, I think it's very important that we talk to the patient before starting the therapy, because there's always nowadays things like fertility preservation and things are coming up. So if we think that any of the therapy can affect the future fertility of the male partner, then it's better that we talk to him about it before initiation of therapy. And after initiation of therapy, we have to see how much testicular damage has been done. The treatment actually depends on that. So it can vary. So it will depend whether if the person comes to me after initiation of the therapy, I'll do the investigations and find out how much testicular damage has been done. But it's better to come to us before starting the therapy so we can talk about fertility preservation and things like that, and what are the effects of therapy may be.
Exactly, madam. Fertility preservation may be an option for the autoimmune disease patient. Thank you, madam. My last question to Dr. Rupin Shah, sir. Sir, many thoughts and many thinking about the ICSI, that the ICSI baby need any long-term follow-up. I think 3 or 4 questions is coming here. And another distressing thing is mentioned by some doctors that when there is a repair of the varicocele, surgical management, after that, what is your success rate in case of this type of cases? Because some mentioned the success rate isn't very satisfactory. So what's your opinion?
I have 2 questions that both need very long answers. I'll be short on the first one. ICSI babies are now being followed up since a very, very long time. We know that there is a small increase in the risk of genetic abnormalities compared to the normal population, but it's still not a very large risk. When we're looking at obstructive azoospermia, the patient I presented is somebody with an epididymal block. If it is acquired due to infection, there's no greater risk. But if it's a congenital epididymal block, then there is some suggestion that this may be related to a CFTR mutation, which will then have risk to the child, depending on the wife's carrier status. Unrelated, where we do not do reconstructive surgery, but we do aspirate sperm, so vasoplasia cases, certainly CFTR testing is needed. Coming to the varicocele, a very important take-home message for everyone is that only clinical varicocele should be treated to expect a reasonably good benefit. Too often, the gynecologist doesn't examine the patient, sends him for an ultrasound. Ultrasound picks up a varicocele, and you tell the patient you need surgery. And very often, it's only a subclinical varicocele, and the patient will not benefit. Clear guidelines from the ASRM and all the other bodies that currently we do not recommend surgery for a subclinical varicocele. When you operate a properly selected case, 2 out of 3 men should have good improvement, and about 30 to 40% should achieve a natural pregnancy.
Thank you. Thank you very much for the wonderful answer, sir, and very clarifying answer. I would like to give thanks from FSSB to the 3 renowned speakers for a very fantastic session on male infertility. Hats off to all of you, sir. And now I'm going to taking the chairperson remark. First of all, I am talking towards Professor Shahnaz Choudhury, madam, the honorable former head of the Department of Chattogram Medical College and the former president of Chattogram branch of OGSB. Madam, please unmute yourself and give remarks on first presentation, and you talk, please, madam.
Thank you, Dr. Sharmin, for wonderful moderation of a very beautiful session. First of all, I would like to say that male infertility is a silent, explored and concealed subject so far, but nowadays there are evolving entities to explore the male also as a partner for the infertility couple. So we have learned a lot from Dr. Thompson's presentation that we have to explore the male factor exactly like that we are doing at present for the female. And we have a thorough history taking is very important, which usually because most of the infertility specialists or OBGYNs are female in our setting, which we most of the time missed out. So it is very important for a thorough history taking, and then subsequent examination of the reproductive organs is very important. Even not by the OBGYN, there should be a multidisciplinary team for evaluation of the male infertile couple. Then the relevant investigation. So far, we are dependent on only the semen analysis parameter, and we have put out the comment to the couple that he has agiospermia or oligospermia or necrospermia, and there is no hope. But nowadays there is a tremendous hope for the male infertility, which causes 30% of the infertility in true sense. So from Thomas' presentation, we should go for step-by-step evaluation of the male partner as well as female partner. Never blame the female. But it is very tragic that though male partner is very much responsible for fertility, but it is the female partner which undergoes all the treatment. You can see that if it is ICSI or IVF, even in the higher line treatment, the treatment bothers to the female partner. So we don't like that only female partner should be blamed or should be treated. Male partner should come into play. And thank you very much for wonderful session. And my special thanks to Professor Maruf Siddiqui and all the teams of Fertility Society for introducing me in this prestigious session. Thank you very much on my core of my heart. Thank you.
Thank you, Professor Shahnaaz Choudhury, Madam, for your chairperson remark. I would like to request Professor Sheikh Zinatara Nasrin. Professor Sheikh Zinatara Nasrin is the Scientific Secretary of Obstetrical and Gynecological Society of Bangladesh and a great academician of our country. Please welcome Professor Sheikh Zinatara Nasrin, Madam, for your chairperson remark. Madam, please unmute yourself.
Thank you very much, Dr. Sharmin, for your kind words. Well, first of all, I'd like to congratulate and extend my gratitude to FSSB for arranging such a wonderful session and make me the part of this event. Thank you so much. Well, today, as a chair, I really enjoyed all the presentations thoroughly, and the deliveries were so engaging that I lost the track of time. And what I found that if I do the summary of all the presentations, I feel that from today, all the gynecologists, specialists, they will deal male infertility with much confidence than ever before. If I come to Dr. Thompson Masterson, well, you really describe the whole evaluation of male infertility so precisely with your allocated time that really, really mesmerizing. And actually, we do a semen analysis, we do lots of investigations, but today you have highlighted rightly, why should you go for 17-hydroxylipogesterone? When should we go for the semen or sperm DNA fragmentation? And when should you really go for the sperm aneuploidy? Thank you so much for your wonderful thought-generating presentation. And if you go to Dr. Tanjeem Sabina Choudhury, well, it's a wonderful, I mean, she has described the treatment of male self-fertility in such a way. And I strongly believe that her presentation enlightened, illuminated all the gynecologists as well as the specialists how to deal really in our daily practice. And also you have rightly emphasized the lifestyle modification that I really agree with you 100%. And of course, I appreciate you that you have told that we have to be very careful regarding the exogenous gonadotrophins as well as the testosterone. Thank you so much for your evidence-based brilliant talk. And next, if I go to Dr. Rupin Shah, who is a very renowned in this content. Well, your presentation was fantastic. I mean, I really, really appreciate the evidence-based, informative, in-depth discussion. And you have rightly mentioned the pros and cons of vasoepididymal anastomosis. Really, we're scared of that. But you have rightly said, why should you go for? And the video you have showed us today, that will boost us to go for the microsurgery. Thank you so much. And the last line you have said that the patient loves nature. We love too. And your presentation will be ever memorable. With this, I would like to stop here. Thank you very much.
Thank you. Thank you, Professor Sheikh Zinata Nasrin, Madam. Thanks to all the chairpersons, all the speakers. And also I like to thank especially the organizer for taking all the troubles and hard work, and special thanks to Professor Maruf Siddiqui for the hard working to make the conference successful and give me the opportunity to be the part of this conference. And last of all, I just want to take one thing, that is we start with the unspoken sorrow of the fertility, that is the male fertility. I think is perfectly judged about all aspects discovered by today's session. So thanks to all. Now over to Dr. Benazir Haq to conclude the session. Thank you.
Thank you, Dr. Sharmin Abbasi, for your wonderful moderation. Really, it was an excellent and informative session. My heartfelt gratitude goes to all learned speaker, Dr. Thomas Masterson, Dr. Tanzim Sabina Chaudhry, and Dr. Rupin Shah. And thank you, Chairperson. I would like to give thanks our valuable audience for patiently hearing. Another big thanks goes to Incepta Pharmaceuticals for their scientific support. And now the session is almost over. Before entering into the next session, let's enjoy a commercial break. Thank you.
Thank you.
কি এটা কি সাউন্ডলেস নাকি আমি কানে শুনছি না?
Soundless.
Sound নেই স্যার।
ও তা ভালো।
হ্যাঁ, আমরাও শুনছি না মারুফ, আমরাও শুনছি না।
যাক আপা, থ্যাংক ইউ।
এই আসতেছে মনে হয় সাউন্ড, আসে নাই? সাউন্ড নাই, দেখা যাচ্ছে ভালোই।
Marufa, can I start?
মারুফ, জ্যোতি শুরু করো।
Yes. So ladies and gentlemen, participants from home and abroad, Assalamu alaikum and good evening to you all. I am Dr. Famida Shamin Jyoti, currently working as Assistant Professor in Department of Obstetrics and Gynecology of Bangladesh Medical College. Welcome you all in 6th International Virtual Scientific Conference of Fertility and Sterility Society of Bangladesh. Today, our session is on interactive scenario-based panel discussion on endometriosis. The session will be chaired by Professor Firdausi Begum and Professor Saleha Begum Chaudhry. Professor Firdausi Begum is President OGSB and immediate past President of SAFO, and she is currently working in Ibrahim Medical College and Badam. She is the focal point of Bangladesh FIGO initiative for preventing unsafe abortion and PPH bundle project. Our next chairperson is Professor Saleha Begum Chaudhry, who is the Secretary General of EASB, Organizing Secretary FSSB, and past Secretary General of OGSB. She is former Chairman of Department of Obstetrics and Gynecology of Bangabandhu Sheikh Mujib Medical University. It's really a strong debate as to whether surgical resection will improve pregnancy potential or ART will be necessary. Let's see what our 4 eminent panelists talk on it. Today, the panel discussion will be moderated by the Joint Secretary of FSSB and Country Representative of Aspire, Professor Maruf Siddiqui, who is currently working as Professor and Head of the Department of Infertility and Reproductive Medicine, Anwar Khan Modern Medical College and Hospital. Now over to you, sir, for conducting the rest of the session. Professor Maruf.
Thank you so much, Jyoti. So now we have moved to the last session. It's a panel discussion from HIFU to all the sperms and now back to endometriosis. We are very happy to have chairpersons like Professor Ferdowsi Begum, who is the president of OGSB, and Professor Saleh Begum Chaudhary is the ex-secretary general of OGSB. So in this session, we do have 6 panelists. Can we have the CVs of the panelists first? Okay. So our first panelist is Major General Professor Lija Chaudhary. Unfortunately, Lija Hapa suffered a small eye injury today, and she had undergone small operation. So unfortunately, she will not be able to attend. Next one. Our next panelist is Professor Munira Ferdowsi. She is the professor of OBGYN and is the current head of OBGYN in the Department of Shahid Sarwardi Medical College and Hospital, Dhaka. Professor Famida Jamin is also last minute has some personal involvement, so she regretted that she would not be able to join. Next one. Professor Hosne Ara Baby, she is working as a consultant OBGYN and fertility specialist at ICRC endoscopic surgery. She had a training from endoscopic surgery at the Ethicon Institute of Surgery Education, training on infertility and ART at ICRC, and training on infertility and ART Institute of Reproductive Medicine, Calcutta, India, 2009. Dr. Renuma Jahan, who is working as an OBGYN and infertility specialist, and he's a consultant OBGYN specialist working at Square Hospitals. And our last panelist is Professor Mafruha Khanum Porag, who is now currently working as the professor and head of the Department of OBGYN, USTC Medical College, Chittagong. She's an infertility specialist and a consultant of Surgiscope Fertility Center. So welcome to all of the panelists. We have tried to construct some scenarios which are actually practically based and more or less accustomed to our daily practical life, what we deal. So let's start with the scenarios. Farjana, could you please have the, okay, I will share the screen. Okay. Farjana, তুমি share করছো?
জি স্যার।
আচ্ছা ঠিক আছে করো। So the first scenario is as Lisa Appa is not there, we will go to Professor Munira Ferdowsi. Appa, this is a difficult one, I think. So a 27-year-old lady married for 2 years attended to you with an ultrasound report having a chocolate cyst on the left ovary, which measures about 4 to 4 centimeters in size. She complains of long-standing dysmenorrhea and wants to conceive now. So how do you plan to manage her? There are several components. She has got a chocolate cyst left ovary. She has got long-standing dysmenorrhea, but again, she wants to have children now. So how do you solve this difficult one? Professor Munira Ferdowsi.
Assalamu alaikum to all of our senior professors and our panelists and all of here present here. Thank you, Maru, for inviting me such a nice seminar and as a panelist. Our scenario is a 27 years lady, married for 2 years, attended with ultrasonography report of 4 to 4 centimeter chocolate cyst. So here we should give attention to the age of the patient. Her ultrasonography report shows chocolate cyst, the size of the chocolate cyst, and she is suffering from the long-standing dysmenorrhea. And now she wants to conceive. So what is our management protocol? here the cyst size. Cyst size is very important because I think the cyst size is not so much big, but here is important that she is suffering from dysmenorrhea. So pain is important thing. So how will we relieve her pain? So what should our next management protocol, and how will she go to the plan for baby planning? So we know that endometriosis, that means it is the endometriosis here. Endometriosis causes sustained reduction of the ovarian reserve through both physical mechanism and inflammatory reaction, which result in the production of the reactive oxygen species and the tissue fibrosis. And the severity of the endometriosis is related to the ovarian reserve. So endometriotic tissue, so what is our next plan? In that case, if we plan for her management protocol, so we should advise her to planning her pregnancy. So she will continue her management protocol. She will planning her baby planning, and she will try for pregnancy. So here I advise her, if pain is severe, then she will take for short period Dynogest, 2 to 3 months or 3 to 6 cycle. If pain is subside, then she will go for the management protocol for baby. Thank you very much.
Okay, Yapa. So as far as I understand, you want to put her on Dynogest for maybe 4 to 6 cycles. Maybe 4 to 6 cycles, and then obviously putting her Dynogest is going to decrease the dysmenorrhea she is having, and maybe she will have some reduction, some degree of reduction, considering the size of her cyst. But obviously, she is not going to conceive by that time. So, what do you think? After 6 months, she will have less dysmenorrhea and reduce cyst size, and then you want to try? What do you plan?
I think in this period that her cyst size is reduced, and in this time we can go for another investigation. So we can go through the hysterosalpingography, her tubal patency is okay or not. We can at the time we can observe this, and we after 2 months we can reevaluate that her cyst size is regressed or not. If the size is regressed, then she can go for the baby planning.
Baby planning, okay. If you think that the cyst size has regressed and the dysmenorrhea has reduced to some extent, what do you want to do for her baby planning? Just keep her on natural cycle, or do you want to induce, or do you want to go for IUI? What do you want to do?
At first, we don't want to go for any other trial. We go for the natural trial. Patient couple will go through the natural trial. If natural trial for 2 to 3 months and then it is not conceived, then go for the another treatment option.
Okay, Apath, thank you. But I think if you put her on Dynogest, she will have maybe a reduced cyst size. Then after 4 cycles, you stop the Dynogest and you start giving a natural trial. Again, the cyst is going to increase in size. So will you gain anything by that procedure?
If it is happened, then we go for the ovulation inducing drug or IUI protocol.
Can I put something?
I will come to you, please. I don't want the chairpersons to just sit idle because it's a panelist session. So can I have the opinion of our chairperson, Professor Saleha Begum Choudhury? Madam, you have listened to the situation. Do you think laparoscopy does have a role here? You want to proceed for laparoscopy or not? You want to go for a conservative treatment? What do you want to do?
Now, in this, thank you, Maro. In this particular case, in fact, I do not like to go for laparoscopy because she is already on, she has been put on Dynages therapy. So some regression of the size as well as dysmenorrhea also subside. So after 3 to 4 cycle, I go for ovulation induction and monitoring the ovulation, and if follicular size is, that is, if I get that is a mature follicle, in that case I will go for IUI.
Maruf, can I comment?
Of course, madam, of course, please.
Thank you.
It's our session. Everybody can come. Please.
I actually, what I do in practice, that this size is not so much bigger than we should do the laparoscopy first. What I do this blood for CA125. If it is normal, then I go for Newgist or Dynagist, as Munira has said, it's quite okay. And then after 3 months, if that size is not so reduced, then I go for laparoscopy and also the tubal testing. But in just a nullipara patient, I usually don't like to go for hysterosalpingography, because you know that there is some types of subclinical infection. So then after, and if there is a reduction of the size, then we can have the ovulation induction, as Saleh has said. I think it is the procedure. Actually,
I also, Dr. Maruf, I also agree with Marufa, because if we do not get any improvement regarding the size of the cyst, in that case we can consider laparoscopy, because for a couple of years, in fact, laparoscopic cystectomy has been considered as a standard treatment. But however, role of surgery is now still controversial because of damage of ovaries, and so over poor declination of AMH level, poor ovarian reserve. So considering in that case, we have to go conservatively with a conservative approach. But if there is no improvement, in that case, I will go for laparoscopy for further evaluation and also necessary steps, that is an intervention if the patient needs.
Okay, thank you, madam. I think Dr. Parag. Oh, sure, Baby Appa and Dr. Parag. Everyone wants to give opinion.
Yes.
That's good. Very good. Please, Baby Appa, what is your opinion?
One thing, in case of, we know the fate of the endometriosis. In case of endometriosis, our aim is to reduce the time to concept or to pregnancy. In this case, I prefer to do the laparoscopy first, because not only do the cystectomy, but to see the conditions of the tubes. And also after seeing the conditions of the, without seeing the condition of the tube, you know, the in endometriosis, the tube-ovarian relationship is usually disturbed, and there is extensive adhesions. And this case, I think the 4 centimeter chocolate cyst this is a case of stage 4 endometriosis, severe endometriosis. Ideally, after cystectomy, she needs ART. But in our situations, what we can do, we do first the laparoscopy, then the partial cystectomy, keeping all the procedure to preserve the ovarian tissue. And also after laparoscopy, we can detect the AMH level. If it is better and the tubal patency and everything is good, then we can proceed for ovulation inductions or 6 months expectancy, then ovulation induction, IUI and ART. But if her AMH, we don't know the conditions of the other ovaries, and also we don't know know her AMH level. If her AMH level is low, which is usual in these cases, then the treatment will depend on AMH level. If her AMH level is very poor, and it happens even at 27 years, small chocolate cyst, then we may have to go for ART first, ART directly. But if we patient cannot manage, or we can consider her socioeconomic conditions, we can do the conservative treatment first and then ART.
Okay, thank you, Appa. So what I get that you want to proceed for.
Maruf,
আপা,
can
এটা
I comment?
একজন করে শেষ করে নি, ওনার কমেন্টটা বলে নি।
Yeah,
So you wish to proceed for laparoscopy. I understand. You said that you want to go for AMH. That I think that is important. But you said that it's a stage 4 endometriosis. I think, madam, only cyst size sometimes do not indicate which size of endometriosis it is. So unless you go for laparoscopy, it's difficult to comment on the degree of endometriosis. But AMH is very important.
But it is in
Please,
4
our chairperson,
centimeter,
Professor
sir.
Ferdowsi. Professor
4
Ferdowsi,
centimeter
become.
is okay.
Maruf, to me, it's not. It doesn't seem such a complicated case. She's 27 years old, and I think this is the first time she's diagnosed as a case of chocolate cyst, which is 4 centimeter diameter, which is less than the size which is indicated for direct laparoscopy. So I think I'll go for Maria's side. We'll go for Dynagist. Hopefully the size is reduced and we can go for lateral ovulation induction, and may defer the tubal assessment for a few months maybe, because this doesn't seem to me, as has been presented the case, as such a complicated case. And this case are we often facing. We do not always go for laparoscopy. And as far as I understand, the protocol also says that. Thank you so much.
Okay. Dr. Parag, Appa, you want to add something?
Yes, actually, I want to, Assalamu alaikum, madam. Thanks to everybody. Dr. Maruf Siddiqui, one thing is, one add to here that everybody is stating we are just that we can use Dynagist, but Dynagist we can use alternate that we can go for the GnRH agonist for 2 to 3 months, then cyst size will be regress. As there is no evidence, I don't know any evidence is there or not that Dynagist causes the pain relief only for the dysmenorrhea also, and also patient wants to conceive now. So if we can go for the GnRH agonist for 3 months consecutively, then down regulation, then we can go for that the ovulation induction like COS. Then we can go for IUI 1 to 3 cycle. This can be ASRM guideline also suggests that minimal endometriosis like that, this is minimal stage 1 or stage 2. This is excellent result for the controlled ovarian stimulation with IUI for 3 to 6 cycles. If we don't know the patient's husband's parameter like semen analysis may be associated with the husband's parameter like that what like severe oligosteroteratospermia, then we can proceed for the ART. But before going to laparoscopy or anything, we can try for super ovulation and then for the IUI for 3 to 4 cycles as the alternate of Dynagist. Dynagist is easy and it is also inexpensive for our patients. But my opinion is like that. GnRH is followed by super ovulation.
Thank you, Appa. This is actually seen where different people will have, not that someone is wrong and someone is right, but different people attend them different way. So, but one thing I would like to share with Dr. Parag that GnRH is quite expensive, and Dynagist in recent studies shows very good efficacy compared to GnRH. So Dynagist reduces dysmenorrhea.
Yes.
And it's an oral drug, so compare, it doesn't have the side effects of GnRH. So Dynagist uses a good drug. But it is not all
মারুফ শোনা যায় না, মারুফ শোনা যাচ্ছে না,
কথা শোনা যাচ্ছে না আমারও। Laila pa, unmute, please.
বলছি কি যে এরপরে না হয় নেক্সট কোশ্চেনে যাক
Okay, Farzana, please share the screen.
সেটাই এটা তো শেষ হবে না এটা
Yes, Farzana.
Individual experience and individual
Yes. So can we go to the scenario 2 until Maruf sir is not present?
No, okay, sorry. There
Yes,
has been.
he's here now.
Can you hear me now?
Yes.
Yes, now.
Maybe there's a internet problem. So can we do one thing, that we put her on Dynogest for 3-4 cycles, try to assess whether the cyst is reducing on size. If the cyst is has reduced on size, you can go for ovulation induction or IUI, that is okay. But if the cyst size is not reduced, or if it begin to increase after giving ovulation induction, then maybe if the MH is good, we may have to plan for a laparoscopy followed by ovulation induction. Maybe we can go that far way. I think we have very good opinion from different people. So let's proceed for the next one. Okay, can you see the scenarios? আবার শেয়ার করা লাগবে। Okay, this is the second slide. Can you hear me? Okay. So this is the next slide. A 32-year-old woman presents with a right-sided chocolate cyst, which is 4 centimeter size. So this is nearly the same scenario that we have in the last case. Only problem is that she doesn't wish to proceed for laparoscopy now. And this patient, we know the AMH. Her AMH is 1.2, but still she has a chocolate cyst of 4.4. So how do you plan to treat her? May I go to Dr. Renuma Jahan? Apa, what do you want to do with the patient?
Thank you so much, Dr. Maruf, and give me privilege for such prestigious conference. Assalamu alaikum, my respected madam. A 32-year-old woman with right-sided chocolate cyst of 4 into 4 centimeter size, just in front of me, with her AMH level is 1.2 nanogram per ml, and she doesn't wish to proceed for laparoscopy now. So how can I counsel her, and what will be the management? So first of all, we have to know as it is primary or secondary infertility. If primary infertility means she has no children before, so we have to counsel her properly, as the chocolate cyst or endometriosis is a progressive disease. It will progress, and it is the cause of her, it may be the cause of her low AMH level, that is the low ovarian reserve. There might be the possibility of tubal damage and other condition that might be caused by endometriosis. So we should be counsel her regarding her pregnancy, and if she doesn't want to go for laparoscopy, and I think she is treated before for infertility, then without knowing the tubal factor, I may consider her for the case of artificial reproductive technique. And if this is the case of secondary infertility, that is she had children before, then we may proceed her for natural pregnancy to try for 2 to 3 cycles, with the knowledge that cyst size may be increased. There may be chance of laparoscopy in future for increased cyst size, and if she want to wait for another 2 to 3 cycles, she may go for Dynogest to reduce the cyst size, and then may she go for planning her pregnancy. So I think I have to think whether it is primary or secondary infertility, and I will be manage the case like that. Thank you so much.
So Apa, what I understood that you said that if the patient doesn't wish to proceed for pregnancy now, then we can put her on Dynogest several cycles.
In case of secondary infertility, I think, and in it is primary subfertility, then I might offer her artificial reproductive technique, I think.
Go straight for ART.
Yeah, because her AMH level is low, and she is 32 years old lady, and there may be chance of increase her cyst size and other factors that might cause her cause of subfertility for endometriosis.
Apa. Can we do a simple hysterosalpingography to see whether the tubes are open?
Okay.
And she has got a cyst on the right side, so maybe we can induce her to develop a cyst on the left side and go for IUI. Can we plan that way by passing the
Actually, as she has endometriosis, we don't know what is the stages of endometriosis, because we know staging is done by laparoscopy. So in that case, I think hysterosalpingogram is not good for her, because it might cause infection. On the other side, she is suffering from endometriosis, which is not suitable for her also.
But Appa, she doesn't wish to proceed for laparoscopy now. So
Yes.
can we give her an option to be pregnant using the opposite side and just have a tubal assessment through hysterectomy? Is it possible? Can we have the opinion of others? Anybody wishes to volunteer what we can do in this case? Can we have the comments of the, please? Anybody?
In this case, I want to do like you, hysterosalpingogram first, and to see the tubal patency. Then I would proceed her to do IUI. But before going to IUI, COS is mandatory. And if we can go for superovulation of the ovaries of the left ovary, I think this is normal. Right ovary is chocolate cyst, but if there is left ovary and MH 1.2, this is possible to do the controlled ovarian stimulation with IUI for 3 to 6 cycles. Then if failed, then I will not waste my time, as she is 32 years and MH is 1.2. But before going to ART, we can go for IUI.
Exactly. So I think the rational way may be to counsel that if you don't want to proceed for laparoscopy, we can go for a tubal assessment with hystero, which is not very standard, trying for go for 2-3 cycles of IUI. But if you don't conceive within these cycles, you may have to proceed for ART if you want to bypass the laparoscopy. Can we do that? Saleh, madam.
আমি একটু বলবো?
Okay.
আমার ক্যামেরাটা একটু ডিস্টার্ব করতেছে, তাই দেখা যাচ্ছে না।
আমি মারুফকে একটু বলি, I also agree with Dr. Maruf, because first of all, I want to counsel with the patient that she needs laparoscopy because her age is 32 years old. Though time of infertility was subfertility not mentioned here, and her MS is 1.2 nanogram per ml. This is good, but not so good. So in that case, I counsel her about laparoscopy, need for laparoscopy, and still if she is confused or that is refused. If she refused the laparoscopy, even after counseling, in that case, I will go for do a hysterosalpingography, and that if I see both tubes are patent, in that case I go for IUI, ovulation induction, and I will.
আমি একটু বলবো মারুফ?
রাশিদা, আমি দেখতে পাচ্ছি না আসলে
আপনাকে, আমি বুঝতে পারছি। ক্যামেরাটা ডিস্টার্ব করছে একটু।
ওকে, হ্যাঁ শিওর, বলেন।
আমি বলতে চাচ্ছি যে পেশেন্ট ল্যাপারোস্কোপি করতে চাচ্ছে না, কেন চাচ্ছে না আমি সেটা জিজ্ঞেস করব। সে কি ভয় পাচ্ছে? তাহলে তাকে কাউন্সেলিং করব, অভয় দেব। টাকার জন্য করছে না, তাহলে আমি বিনা টাকায় করে দেবো বা গভর্নমেন্ট হসপিটালে। বাট ল্যাপারোস্কোপি মাস্ট। 1.2 is not so bad image. ল্যাপারোস্কোপি করে পেলভিস না দেখে, এন্ডোমেট্রিওসিসে পেলভিস না দেখে ট্রিটমেন্ট করার কোনো যুক্তি নাই। এন্ডোমেট্রিওসিস নিডস অ্যাক্টিভ ম্যানেজমেন্ট, এবং এন্ডোমেট্রিওসিস মানেই তারা কিন্তু যত শূন্য ওভারি পাই এন্ডোমেট্রিওসিসের। এন্ডোমেট্রিওসিস দেখলে আমি ভয় পাই। এন্ডোমেট্রিওসিসকে কিন্তু সিরিয়াসলি নিতে হবে। এবং আগের পেশেন্টটাও অ্যাকচুয়ালি 24 ইয়ার্স হলো, তার ডিসমেনোরিয়া আছে। ডিসমেনোরিয়া থাকা মানে তার কিন্তু পিভি করো নাই, ভিতরে হয়তো দেখবা যে তার নোডুল আছে, থিকেনিং আছে। তারও কিন্তু ল্যাপারোস্কোপি করে দেন ইফ এভরিথিং সিস্টেমি করে টিউবাল যদি ফ্যাক্টর ভালো থাকে, দেন ন্যাচারাল ট্রায়াল, ইন্ডাকশন আইওআই, আইভিএফ, স্টেপ বাই স্টেপ ম্যানেজমেন্ট। কিন্তু এন্ডোমেট্রিওসিসে পেলভিস না দেখে ট্রিটমেন্ট করার কোনো যুক্তি নেই, এটা হলো কথা।
এক্স্যাক্টলি আপা, বাট অ্যাকচুয়ালি এটা আমি বলেছি বিকজ এই পেশেন্ট হয়তো মানে শি হ্যাজ রিফিউজড ফর আ ল্যাপারোস্কোপি, সো মেবি উই ক্যান কাউন্সিল যেটা না হলে ডাইরেক্ট এআরটিতে যেতে হবে, ইন হুইচ কেস উই ডোন্ট হ্যাভ টু
আইদার ল্যাপারোস্কোপি অর এআরটি।
ডায়াগনোসিস দিতে পারি না এই পেশেন্টকে, ডায়াগনোসিস তো ইজিলি দেওয়া যায় পেশেন্টকে, কারণ
দিলে তো
আমি প্র্যাকটিক্যালি আমি কোনটা পেটেন্ট তো ওখানে লেখে নাই যে পেটেন্ট নাই, সবসময় তো আমরা হিস্ট্রোসালপিংওগ্রাফি করি না। আমি এই কেসে ডায়াগনোসিস দিয়ে 3 মাস দেখে যদি দেখি সাইজ ছোট হয়েছে তাহলে তো আমরা ওভুলেশন ইন্ডাকশন শুরু করব, আর যদি সাইজ ছোট না হয় তখন আমরা ল্যাপারোস্কোপির সাথে আমরা
1.2 কিন্তু লোয়ার লিমিট অফ নরমাল, 1.2 পরেই কিন্তু ভেরি লো এমএইচ।
ওখানে তুমি ল্যাপারোস্কোপি করে ওই জন্য 3 মাস সময় নিতে চাচ্ছি আমি। যদি পেশেন্টের সিস্ট কমে যায়, অনেক কমে যায়, আমরা 50%, তুমি জানো যে একটা স্টাডি চলছে, তো কিছু কিছু কেসে 50% কেসে কিন্তু একদমই কমে যাচ্ছে আর 50% থেকে যাচ্ছে, সেই 50% কেসে আমি তখন ল্যাপারোস্কোপি করব, একসাথে টিউব টেস্টিং হয়ে যাবে।
So it's a controversy again, these are about controversies, you can put her on
next কোশ্চেনে চলে যাবে, কন্ট্রোভার্সি থাকবে।
next question আস্তে আস্তে। হ্যাঁ এই পরের স্লাইডে গেছো ফারজানা নাকি?
না মারুফ, তাহলে এটার এন্ড মেসেজটা কি হবে? হোয়াট ইজ দ্য বটম লাইন মেসেজ?
আমি কিন্তু ওই সিনারিও গুলো দিয়েছি যেগুলো অ্যাকচুয়ালি কন্ট্রোভার্সিয়াল, একদম 100% অ্যান্সার কিন্তু বলা যাবে না। ইউ ক্যান, কারণ পেশেন্টের কিছু কিছু মতামতকে তো কোনো সময় গুরুত্ব দিতে হবে। সুতরাং এই ক্ষেত্রে আমার মনে হয় বলতে হবে যে ল্যাপারোস্কোপি করা ভালো। তুমি যদি একেবারেই ল্যাপারোস্কোপি করতে না চাও তাহলে তোমাকে কিছুদিন ট্রায়াল দিয়ে এআরটি তে যেতে হবে। আর লাইলা ম্যাডাম যেটা বলেছেন 1.2 হলো 2-3 মাসের ডায়াগনোসিসটা রাখতে খুব একটা অসুবিধা হয় না, যদিও 2-3 মাসে কতটুকু কমবে আমরা জানি না, বাট লেটস সি, কারো কারো কমে, তাদের ক্ষেত্রে লাকি হতে পারি। সো দ্যাট উড বি আওয়ার টেক হোম মেসেজ।
মারুফ একটু চান্স দেব, আমি একটা কথা বলবো এমএইচ লেভেল সম্পর্কে। আচ্ছা, এমএইচ এর কথা যেটা বলেছে যে এটা লোয়ার, এটা দিয়ে কিন্তু একটা মার্কার অফ দা ওভারিয়ান রিজার্ভ, এটা আমাদের ম্যাডামরা অনেক ভালো জানেন, কিন্তু এটা দিয়ে কিন্তু রিপ্রোডাক্টিভ লাইফ স্প্যানটাকে দেখি, কিন্তু ফার্টিলিটি মেজারটা করার জন্য এটা কিন্তু গুড প্রেডিক্টর না, এটা কিন্তু রিসেন্ট স্টাডি গুলো বলছে। আরেকটা কথা বলছে যেটা যে এখানে আছে 1.2 ন্যানোগ্রাম যেটা বলেছে, কিন্তু এটা হচ্ছে ফার্টিলিটি রেটের জন্য যেটা লেভেল বলছে সেটা বলছে 1.0 থেকে 4 ন্যানোগ্রাম পার ml পর্যন্ত। তো সেই হিসাবে এমএইচ লেভেল কিন্তু খুব খারাপ না। আরেকটা কথা রিসেন্ট স্টাডি গুলোতে বলেছে যে এমএইচ লেভেলকে আমরা বাড়াতে পারি যদি আমরা ভিটামিন ডি লেভেলটা দিই। ভিটামিন ডি এমএইচ লেভেলকে বাড়াতে সাহায্য করে, এটা রিসেন্ট স্টাডি গুলোতে দেখা গেছে। তাহলে আমরা যদি ভিটামিন ডি দেই তাহলে সেক্ষেত্রে কিন্তু এমএইচ লেভেল বাড়াতে পারে। যে কথাটা আমার জিজ্ঞাসা মারুফ, সেটা হচ্ছে এত ছোট চকলেট সিস্ট 4.4 into 4 সেন্টিমিটারে, সেক্ষেত্রে আমরা প্রথমেই যদি ল্যাপারোস্কোপিক সিস্টেক্টমিতে যাই, পরবর্তীতে যদি আবারও হয় তখন কি আমরা বারবারই সিস্টেক্টমি করতে যাব? এটা আমার মনে একটা ভালো সিদ্ধান্ত এই ফোরামে দেওয়া উচিত, কারণ আমাদের অনেক জুনিয়র স্টুডেন্টরা শুনছে। সুতরাং আমি 4.4 সেন্টিমিটারে আমি সরাসরি ল্যাপারোস্কোপিক সিস্টেক্টমিতে যাব, নাকি আমি আগে মেডিকেল কনজারভেটিভলি ট্রিটমেন্ট করব, সেটা বড়, সেটা ইম্পর্টেন্ট ইস্যু। আমি যদি কমে যাই না,
প্র্যাকটিক্যালি করি না,
নতুন একটা ড্রাগ এসেছে ম্যাডাম,
আমরা করি না ল্যাপারোস্কোপি, বুঝতে পেরেছো? আজকাল করি না, আগে
this thing we are actually discussing, these are controversial things. তবে আপনি যেটা বললেন যে ভিটামিন ডি এমএইচ বাড়াচ্ছে, এটা জাস্ট একটা স্টাডি, এটা এখনো তো আসলে বাড়ানোর কোনো কিছু তো এখন পর্যন্ত কেউই আসলে আবিষ্কার করতে পারে নাই। আর বিশেষ করে এন্ডোমেট্রিওসিস ইজ অ্যান অ্যাগ্রেসিভ ডিজিজ, এটা তো গ্র্যাজুয়ালি এমএইচ কমিয়ে দিবে বিকজ ইটস কজিং ওভারিয়ান ড্যামেজ। ফলে সেক্ষেত্রে এন্ডোমেট্রিওসিস উইথ লো এমএইচ এটাকে কিন্তু সিরিয়াসলি ডিল করতে হবে। 1.2 হলো উইথ এন্ডোমেট্রিওসিস, ইট হ্যাজ টু বি সিরিয়াসলি ডিল্ড উইথ।
আর এন্ডোমেট্রিওসিস শুধু তো সিস্টটা সমস্যা না, এন্ডোমেট্রিওসিস কজেস ইনফার্টিলিটি ইন সেভারাল ওয়েজ। শুধু তো সিস্টের কথা চিন্তা করতে হবে না, আপনি যত এন্ডোমেট্রিওসিস আমরা ল্যাপারোস্কোপি করি, সঙ্গে টিউবাল প্যাথোলজি মানে রিলেশনশিপটা নষ্ট হয়, টিউবের অ্যাডিশনস থাকে, সেগুলো তো কনসিডার করতে হবে। একটা শুধু আমরা যদি আলট্রাসোনোগ্রাফি ফাইন্ডিংস দেখলাম একটা সিস্ট, আমরা তখন কিন্তু তার ওভারঅল আমরা স্টেজিংটা বুঝতে পারবো না যদি না আমরা ল্যাপারোস্কোপি করি। আর এন্ডোমেট্রিওসিস এটার ফেট এত খারাপ যে আমাদের প্রথমেই একটা উদ্দেশ্য যে আমাদের রিডিউস করবো টাইম টু প্রেগনেন্সি, এবং সেটা করতে হলে আমাকে এই সিস্টকে অবশ্যই ল্যাপারোস্কোপি করে তার ওভারঅল কন্ডিশনটা জানতে হবে, সিস্ট আমরা করে বসে থাকবো না যে আরেকটা সিস্ট হওয়ার জন্য, তাকে সঙ্গে সঙ্গে তাকে অ্যাক্টিভ ট্রিটমেন্ট করে আপ টু এআরটি করতে হবে। এটাই হচ্ছে আমার মনে হয় এন্ডোমেট্রিওসিসের ট্রিটমেন্ট, যেভাবে আমরা টাইম কমাতে পারি।
Let's move on to the next scenario. The next scenario is age 35. This patient had undergone laparoscopy twice in the last 10 years due to endometrium and primary infertility. So she had already undergone through 2 laparoscopies. The HSG shows the tubes are patent. The AMH is only 0.5 nanogram per ml, and you can see only 4 antral follicles in the AFC count. But still, she has got an endometrium of 5 by 5 centimeter right ovary. So what is your plan with this patient? Dr. Hosni Ara Baby, Apa, bolen, ki korben eta?
There is no other options. In this case, we have to do the ART directly, but before doing ART, we have to reduce the size of the endometrioma by aspiration, I think, and that may be done by transvaginally or laparoscopically, only to aspirate the endometrioma, because with this size of endometrioma, we cannot stimulate the ovary. There is less chance of getting the follicles. So in these cases, I advise for aspiration of the endometrioma laparoscopically or transvaginally, followed by long down regulation and ART.
Exactly, because this patient had undergone the laparoscopy twice. এখন আজকাল বলা হচ্ছে যে একবার করলে সেকেন্ড বারই করার সময় অনেক চিন্তা ভাবনা করতে হবে। সুতরাং এখানে 2 বার হয়ে গেছে, আর কোনো ল্যাপারোস্কোপির এখানে আসলে রোল নাই। ইটস আ মোটামুটি ক্লিয়ার কাট কেস, শি হ্যাজ টু গো ফর অ্যান এআরটি। বাট যেহেতু এই সাইজের এন্ডোমেট্রিওমা নিয়ে এগ পাওয়া যাবে না, সিস্ট অ্যাসপিরেশন করা যাবে না, সো ইউ হ্যাভ টু রিমুভ ইট ইন সাম অর আদার ওয়ে। ওকে, লেটস গো টু দ্য নেক্সট সিনারিও, ফারজানা। Okay, this is for Dr. Poragapa, a 33-year-old lady. She complains of irregular parvaginal bleeding. She has a chocolate cyst. She had a chocolate cyst before last conception, which was resolved after pregnancy. She was on Dynogest after the first delivery and stopped it 4 months back. Again, she is having irregular PV bleeding. এটা খুব জটিল সিনারিও না, একটা সিস্ট ছিল যেটা চলে গিয়েছে প্রেগন্যান্সির পরে। এরপরে তাকে ডায়নোজেস্টে রাখা হয়েছিল এবং 4 মাস আগে ডায়নোজেস্ট বন্ধ করা হয়েছে। এখন কেবলমাত্র ইরেগুলার পিভি ব্লিডিং হচ্ছে। উনি সেকেন্ড চাইল্ডের জন্য ট্রায়াল দিতে চান, কি প্ল্যান করবেন আপনি, প্লিজ?
Thank you, Dr. Maruf Siddiqui. Actually, I want to guide her for the irregular vaginal bleeding. I have to find out the cause of irregular vaginal bleeding. As she stopped 4 months back, Dynogest, and Dynogest causes the irregular vaginal bleeding. And after stopping of the Dynogest, we know that the action of the Dynogest persists for last future 6 months. It can be persist. The study shows. So that's why I will just irregular cause of irregular vaginal bleeding, as she want to try for second child. So as usual, I will go for her evaluation of the patient, everything baseline hormone. If irregular bleeding stopped, and on the day of day 2 or day 3 menstruation, I will go for the baseline hormone analysis and also see the image, and also go for hysterosalpingogram to see the patterns.
হ্যাঁ, ঠিক আছে, আমি বুঝলাম, কিন্তু আসলে আপনি কি তাকে ন্যাচারাল কনসেপশন অ্যালাউ করতে চান, ওগুলোসে ইন্ডাকশন দিতে চান, কি করতে চান? আর আপনি ইরেগুলার পিভি ব্লিডিংটাকে কিভাবে ম্যানেজ করবেন?
If irregular bleeding stopped and there is no cause, then I will go for her for natural conception to see everything is okay, baseline hormone analysis okay, her hysterosalpingogram is okay, then I'll go for the ovulation induction and for 3 to 6 months treatment. As she is 30 years, so I counseling the patient as her she has last conception was pregnancy, and she was on Dynogest. So I suggest her for the weekend to conceive, খুব তাড়াতাড়ি কনসিভ করার জন্য বলবো। আর নেক্সট যদি এভরিথিং ইজ ওকে থাকে, দেন আমি ওভুলেশন ইন্ডাকশন দিয়ে তাকে আইইউআই করার চেষ্টা করবো 3 সাইকেল।
পেশেন্ট তো আগে একবার চকোলেট সিস্ট ছিল, কিন্তু তার মধ্যে সে কনসিভ করেছে, সো হোপফুলি দ্য পেলভিস ইজ গুড, আদারওয়াইজ তো সে কনসিভ করতো না। এখন সেটাও নাই। এখন ইরেগুলার পিভি ব্লিডিং যদি পারসিস্ট করে, এটাকে বন্ধ করার জন্য কিছু করবেন?
Yes, I told you that irregular pervaginal bleeding cause dekbo, and then irregular vaginal bleeding stopped by the northeastern or anything. If there is no cause and the regular menstruation is going on, then I will counsel her for the next pregnancy for the ovulation induction.
তবে আমার মনে হয় 33 ইয়ার্স হয়ে গেছে, ন্যাচারাল ট্রায়াল না দিয়ে স্ট্রেট কাট ওভুলেশন ইন্ডাকশনে যাওয়াই ভালো হবে।
ওভুলেশন ইন্ডাকশন আমি বলেছি, ইয়েস ওভুলেশন ইন্ডাকশনই আমি বলেছি।
এই পেশেন্টের 33 ইয়ার্স, তার একটা হিস্ট্রি আছে যে চকলেট সিস্টার। এই পেশেন্টের আমার মনে প্রথমেই দেখা উচিত তার এমএইচ লেভেলটা কত। তা না
yes I told আপা যে বেসলাইন হরমোন যখন আমি করেছি তখন আমি এমএইচটা দেখে নেব অ্যাকর্ডিং টু হার ওভারিয়ান রিজার্ভ, অ্যাকচুয়ালি হার ফলিকল বেসলাইন ফলিকল, এফসি, and also the MH and also the age.
মানে ই করে না যে সবকিছু তার ভালো আছে, কারণ
না আমি সব দেখার পরে আমি চাচ্ছি যে আমি তার সব দেখবো, যেহেতু সেকেন্ডারি ইনফার্টিলিটির জন্য সে ট্রিটমেন্ট নিচ্ছে এখন, তাহলে আমি যদি অন্য কোনো কজ না পাই, এগেন মিনিমাল অর মাইল্ড এন্ডোমেট্রিওসিসও না থাকে, এখন যদি সে এভরিথিং ইজ ওকে, দেন আই উইল গো ফর ওভুলেশন ইন্ডাকশন এন্ড IUI, and if there is, this is my decision.
Okay, thank you so much. We have gone through 4 scenarios. We want to maintain the time, so I think we have nearly come to the end of the session. Let's have some valuable comments from the chairpersons regarding this panel discussion. May I request Professor Firdausi Begum to have her comments on this session. Professor Firdausi Begum.
Yes, thank you so much. It was really, I should say, well participated and very exciting panel discussion. We hardly see or hear something like that, because everyone was enthusiastic to participate. And thank you, Maruf, for presenting the wonderful cases to give us matter of thought, as well as the inspiration for participation. Because endometriosis is a common problem. The cases has been presented today is so common. Often we see encounter this kind of things in our regular practice. So that's one of the very wonderful things, and especially our panelists who participated well, and many issues. I think issues has been brought here. And both the juniors, seniors, experts, I think the infertility specialists and laparoscopic surgeons, general obstetricians and gynecologists all participated here in a very, I think, participatory mood, and showing their concern about the patients all that we presented today. So I really appreciate your selecting the cases, and I must say that we have the protocols, the guidelines, national, international, different guidelines. So we need to follow those, because otherwise, all of us have different opinions. That's true, and experience. But at the same time, following guidelines give the standardization of the treatment, and it came out from this discussion as well that the counseling is important in every aspect of management of endometriosis, whatever the clinical picture may be. Thank you so much.
Madam, may I request Professor Saleh Begum Chaudhuri, the other chairperson, to please have her remarks on this session.
Thank you, Maru. Actually, it is a wonderful discussion, and we have gone through 1 hour discussion. Problems are very common, and session was also very interactive. I think, because everybody opened their mind and given their decisions. But again, I uttered that is Professor Firdausi Begum's word. We have to develop protocol, because in this session we already found there are lots of opinion on same cases. Then not all are not similar decision, similar opinion, similar thinking. So we need protocol. And another thing, I think that is the one thing I think we should know that is we should I know everybody aware about that. That is there is a evidence that when the chocolate cyst or ovarian endometrium is less than 3 centimeter or 3 centimeter, it does not have impact on AMH level. In that case, if patient age permit, it is if younger patient. In that case, we go for conservative approach, and even we can wait 1 year, 2 years. And another, there is also evidence, though I already mentioned before that, the ovarian cystectomy, in case of laparoscopic ovarian cystectomy has been a standard treatment for a long time in case of infertility and ovarian endometrioma. But at present, that is a role of surgery has been challenged because of surgery causes damage to ovary, and not only follicle and cortex, also adhesive lysis also causes, that is reduction of blood supply, that also hamper fertility, as well as safe surgery is mandatory, and it is not always possible. There is inadvertent loss of ovarian follicle due to cauterization or even suturing to ensure hemostasis. So whenever we go for surgery, you always think again. Before surgery, you have to think again and again whether we go. Though infertility treatment, in fact, depends on age of the patient, duration of fertility, as well as AMH level, having got any previous surgery for chocolate cyst, and many other things, and all other things that already discussed. So it is we have to go for a stepwise treatment, but we have to individualize the treatment in all cases. So that is, I think this is a wonderful session, and I also thanks and express my gratitude to organizer for organizing such a wonderful session, wonderful conference. And we have also 1 day left now still, and we will be more knowledgeable with further discussion. Thank you all.
Thank you so much, madam. So now the rapporteur, Dr. Jyoti, will wrap up the session, but please don't leave, because after the wrap up of this session, we will have comments from our treasurer, Professor Laila Arjumand Banu, about this whole day. So please don't leave. Jyoti.
So thank you, Professor Maruf, sir, for your nice moderations of such vibrant panel discussion. So I'd like to thank all the panelists for the time-demanding discussions and the chairpersons for their valuable remarks. And last but not the least, the participants for their gracious presence and also the participations to make this session very successful. So thank you all for your presence and for being with us. So over to Professor Maruf to conduct the Day 1 closing remarks. Thank you.
Thank you. We have come to the end of first day. We had 6 very wonderful sessions. So may I request our treasurer, Professor Laila Arjumand Banu, to give the concluding remarks of day 1. After the remarks of Madam, this session will close. Madam, please.
Thank you, Dr. Maruf. I think I first acknowledge my gratitude to the organizing authority and all the organizing team with Dr. Maruf to give me the responsibility of giving a concluding remarks in this first day session. Already Professor Parveen Fatima has finished, I think, the first part of the session. So I think I will start from our session. That was the session 4. And there was detailed discussion about the 3 presentations, which were excellent presentation. Professor Luigi Mantuvechi, and then number 2, Professor Petro Gubini, so hard name, and Professor Sevele Raja Subramaniam. Actually, that was the hysteroscopic session, and they have shown their hysteroscopy, the one Gubini system, always a very smaller in diameter, only 1.9 centimeters. So it becomes easier to handle these hysteroscopic cases even in the office as a hysteroscope, and also to do the small operations like polypectomy and the submucous myomectomy like this. So this was a very fruitful session. And then the session was the session 5. There was 3 speakers. Dr. Thomas Masterson, he has presented the azoospermia, actually not azoospermia, but the male infertility, how to diagnose and how to go for the testing. And especially he gave emphasis on the sperm testing, the sperm DNA fragmentation, sperm aneuploidy, which we don't actually do usually, and anti-sperm antibody test. So his lecture was also very informative. I think those who deals with the male infertility, they will be benefited much. Dr. Tanzim Sabina Chaudhary has given a very good brief on the treatment of subfertile men, how to approach. And also male factor infertility, actually her presentation was also very simple and also excellent, I think so. So about 50% of the infertility causes by men. Now it has become 60%. So the blame of the woman is going lesser and lesser. So the males are now, we can blame them. So the idiopathic, some cases are the idiopathic, and she enlightened the medical and surgical treatment of male infertility, especially the coenzyme Q10. She has also mentioned this, and I'm not going in details. You have already heard about that or listened. Third speaker was Dr. Rupin Shah. She's a very renowned speaker, obstetric. He has told the obstructive azoospermia, and very beautifully he has shown the different procedure of the operation, how to treat the azoospermic or obstructive azoospermic cases. So thank you thank you, Dr. Rupin Shah. Then there is also the bypass surgery or ICSI. That was his title. Now, and he has mentioned another, the vaso-AP anastomosis. It has a better result than the anastomosis. So it is also a new thing to us, and he has shown us very nicely. And last but not the least, the panel discussion session. It was session 6, and I think it was the most exciting session. And all the participants here, though they are panelists or not, they actually very much inquisitive to participate in the panel discussion. And the word was, the problems are simple, but the solutions are difficult. So what we usually we receive in our day-to-day practice, actually that was a problem Maruf has presented in front of us. So thank you, Maruf, for your actually case scenarios, your selection of the case scenarios, because we have to think about those. And some, I think, though we have individual experience and individual way of treatment, but even then we sometimes have to learn something from our colleagues. So I think the panel discussion was very effective. And endometriosis is always, it is what I can say, it is harmful than the cancer. So you should be always cautious about endometriosis. If you do the surgery, you should do the complete surgery, never do the incomplete surgery. And so another important or surprising thing, that one day one patient came to me, her AMH was only 1.2, and she was just crying, "Madam, I won't have any children in future. Everybody told me." So I have given just simple clomiphene citrate, because the future is not so very prognostic. But surprisingly, after 3 months, she became conceived and come to me. The madam, it worked. So এটা হলো যে মানে আপনি বাংলায় বলি, সবাই এখানে বাঙালি, এটা হলো যে সেই ঝড়ে বক মরে আর কি যেন হয় সেই ব্যাপারে, মানে সবসময় কিন্তু আমরা অনেক কিছু দেখি যেগুলো আমাদের এক্সপ্লেনেশনের বাইরে। We can't explain those things. যে আমরা মনে করি যে এই পেশেন্ট এটা কখনোই মানে কনসিভ করবে না, দেখা যাচ্ছে সেই পেশেন্ট কনসিভ নিয়ে আসছে। তো ইনফার্টিলিটি সাবজেক্ট, যেটা বলি অবস্ট্রাটিক্স এন্ড ইনফার্টিলিটি, এটা হলো যে কেউ কোনো কিছু প্রেডিক্ট করতে পারে না। হয়তো আমার মনে আছে আমাদের টিএচওডি স্যার একদিন এক পেশেন্টকে বলে দিচ্ছিল, তখন তো আমরা পিজিতে ছিলাম, যে তোমার তো বাচ্চা হবে না, তুমি রিকানালাইজেশন করতে হবে। সে 3 মাস পরে সেই পেশেন্ট মানে কনসেপশন নিয়ে আসছে। তো কাজে ওটা দেখা ছিল বাইলেটারাল টিউবাল ব্লক ছিল। তো কাজেই আমার মনে হয় যে আমরা personal experience important, but always we should be methodical. We should follow the guidelines, and we should always have our protocols in our different centers. So thank you very much, Maruf, and everybody for listening me and give me the opportunity to tell something. আমি আমার বন্ধুকে দেখতে পাচ্ছি, সে মানে খুব টায়ার্ড হয়ে আসছে, মানিকগঞ্জ থেকে আবার হারিয়ে গেল। যাই হোক, সামিনা আছে এখানে। তো থ্যাংক ইউ ভেরি মাচ সবাইকে, আবার বলছি থ্যাংক ইউ। এই যে রওশনাথকে দেখতে পাচ্ছি। হ্যাঁ,
আপনি কিছু বলেন, সারাদিন তো কিছু বললেন।
হ্যাঁ সেটাই, রওশনা বলেন, সামিনা
কিছু বলেন।
খুব ভালো হয়েছে, এক্সিলেন্ট। কিন্তু আমি খালি নাম্বার গুনতেছিলাম, 1400 রেজিস্ট্রেশন হয়েছে, 30 জন 35 জনের বেশি না।
না 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 না, এটা তো শুধু আমাদের প্যানেলিস্টদের দিয়েছে, আর বাকি তো সব দেখছে।
1400 এলাও করলে তো এখানে ম্যাডাম হবে না, এটা খালি কেবলমাত্র আমরা যাদেরকে লিংক দিয়েছি তাদেরকে দেখতেছেন ম্যাডাম।
তুমি একটু সংখ্যাটা বের করতে, তাহলে সবাই জানতে চাইছে।
ওই হিসাবটা সাথে সাথে হয়তো ওরা দিতে পারবে না, হতে একটু পরে।
আমি ফারজানা বলুক, আমি সবার সামনে সবার কাছে বলতেছি। যাই হোক,
ভালো।
আমি সারাদিন রওশন আপাকে পেলাম না কেন?
মানিকগঞ্জে ছিল, মানিকগঞ্জে ছিল।
রওশন আপা আপনি কোথায় ছিলেন? আপনি তো ছিলেন না।
পারবিন আপা, আপনার
খুঁজে গেছিলাম,
খুবই ভালো ছিল, সবারই খুব সুন্দর হয়েছে আপা। পারবিন আপা